Hello everybody. مرحبا جميعا. يعطيكم العافية. دكتور طالب. طيب, okay. Welcome everybody to our first neonatology webinar. I would like to thank all the speakers and moderators, and especially Dr. Itawi and Dr. Monika kaushal for accepting our invitation. We have a small word from Dr. Taleb, who is the coordinator of the Neonatology Club, but I don't think he is with us. Maybe there is an internet disconnection problem. So let's be on time and start our first session. The moderator of the first session will be Dr. Robert Sacy and Dr. Dunia Nakhoul. Please go ahead. And our first speaker will be Dr. kaushal. Let's go ahead. Dr. Nakhoul.
Good afternoon, everybody. First, I would like to wish a happy Mother's Day to all the mothers in our club and joining this webinar. We are honored to present our first speaker, Dr. Monika kaushal. Dr. Monika kaushal is graduated from India, from All India Institute of Medical Sciences. She got a master in pediatric from PIGI MER. She got a diploma in neonatology from the UK, and she's a fellowship from the Royal College of Pediatrics and Child Health. She's currently working as a consultant neonatologist and head of Department of Neonatology, Emirates Hospital. She's head of Department of Neonatology, Irani Hospital. She got various publications in national and international journals. She's also a faculty in various national and international conferences. She has made a chapter in Protocol Book of Neonatology. Dr. Monika is the editor of Indian Journal of Child Health, Al-Azhar Medical Journal. She's been also awarded the Young Scientist Award in the 13th Federation of Asia and Oceania Perinatal Society, Malaysia. Thank you, Dr. kaushal, for accepting our invitation. The floor is yours.
Thank you very much for the invitation, for the nice kind of a start, neonatal webinars. So I'll be talking on emerging evidence for resuscitation guidelines 2020. I will actually like more to highlight on the facts that how they come to the all these guidelines. So different people and a lot of efforts go in coming up with the guidelines, and European Society, American Society, and Australian Society all get together. And the first for 2020 came in neonatal life support. And how do they come to this? I want to just take you a journey. How do they come to the guidelines? So the task force undertakes 3 types of evidence review: evidence update, scoping reviews, and systematic reviews. So if you go beyond 2015, where the previous guidelines were, from 2016 to 2020, there were 3 scoping reviews on effective briefing and debriefing, suctioning, positive pressure ventilation. There were 12 evidence updates on prediction of need of respiratory support, initial steps, use of PEEP, CPAP, CPR, volume infusion, and post-resuscitation care. And there were 7 systematic reviews on intubations and suctioning of meconium strain liquor, sustained ventilation, oxygen use, interim and preterm epinephrine, and so on and so forth. So a lot of efforts go in. And when you look at the chart which you see, actually it is involving a lot of things like physiology of asphyxia, therapeutic hypothermia, cot management, heart rate assessment, chest compression, epinephrine, meconium stain, room air versus oxygen, targeted saturation. So these is how the NRP comes up. And I would first highlight to you what are the new things and how did they emerge. So, and then we can go one by one, and you can stop me when the time is over, because its talk is big. It's a big topic in itself. NRP renewal to maintain the skills. Actually, we were renewing every 2 years. And if you must have seen in your unit, you know, people tend to forget. You cannot have that much of memory. So more frequent sessions in the units to maintain the skills should be done. And that should be every 3 to 6 monthly. And we are coming up with simulation programs, and we do in our units every now and then these renewals. And then anticipation of the resuscitation need. So every birth should be attended by one person who is trained in NRP and who should know how to give positive pressure ventilation, and he or she should be only responsible to take care of the newborn and not the mom. So this is another thing which they have given very clearly. Then cord clamping. So if you look at the timing of the cord clamping, and you know that from 60 seconds to 5 minutes it may range, and the outcomes were seen in 22 RCTs. For preterms, if you look at the benefit for less than 1 month, it has improvement in transitional circulation, less need of blood transfusion, NEC and IVH. And after 1 month, it is having a high hematocrit ferritin levels. And for term babies, after 1 month, they are seen to have lower anemia and improved iron stores even up to 4 to 6 months. So it's important. And if you cannot do the delayed cord clamping, can you do the umbilical cord milking? Initially, it came up as a very big thing when they said that if you do umbilical cord milking, it lowers the ROP requiring surgery if you do it for babies between 23 to 27 weeks. And soon after this study came that if you do a cord milking, what happens is that if you are milking the vein, because the baby is not breathing of his own, so there is a poor respiratory effort and there is a high PVR, all this blood is going to go to the systemic circulation and straight away to the brain. And from the umbilical artery, again, pulmonary artery is closed, so it is not going to reach there. And so it is going to go directly to the descending aorta, and from there to the carotid flow, and this is going to lead to IVH. And hence, no cord milking in extremely preterm infants is advised. For a term baby, yes, of course, you can do the cord milking if you cannot do the delayed cord clamping. So the timings of the delayed cord clamping, different studies have shown that it doesn't make a difference, and they didn't find a much difference. So at least more than 30 seconds, and if possible, 60 seconds delayed cord clamping should be done as for now. And there are various other studies which we are waiting for the results to come out if we can tell exactly which time is good for the delayed cord clamping. Now, the problem which happens is when the baby is asphyxiated and you want to clamp the cord late, you have a very short cord, maintaining sterility is difficulty, inadequate access to the personnel and difficulty to temperature maintain is there. And hence there is a different resuscitator trolleys which can go near the moms are there. And recently in UAE, we have this trolley which has come up, and this will help us a lot. Now, before the birth, 4 pre-birth questions were gestational age, amniotic fluid clear or not, additional risk factors, and how many babies. I think from how many babies it is going on to the umbilical cord management. Then the oxygen in the delivery room. So there were systematic reviews for how much oxygen should be started in the delivery room for babies less than 35 weeks. And they were looking into their data on mortality and the long-term outcomes. And after 2015, there were 2 studies which gave a different results altogether. Remy et al. Showed that lower oxygen group had a worse outcome, and Oegel et al. Said that higher oxygen group had a bad outcome. So these are conflicting results which we get, and hence if you combine all these results and look at the studies, if the studies with the high risk of bias, they will see they are showing to have favoring the higher FiO2, and the low risk of bias are favoring lower FiO2. And if we combine both of them, there is no difference. And similarly is for the requirement of the ventilation, similar results. So, and if you see the confidence interval, it is quite wide in these kinds of results. For the critical outcomes of long-term mortality, 1 to 3 years, they have found to be that lower FiO2 is beneficial. And hence, what does the ILCOR say? So ILCOR suggests that we should start between 21 to 30% and not 60 to 100% in babies less than 35 weeks. However, there is a difference in the different gestation, which is very important. More than 31 weeks, air, 28 to 31 weeks, air or 30%, less than 28 weeks, 30%. And at 5 minutes, you should look at the saturation, which is important. They should have a saturation of more than 80%. If the babies at 5 minutes didn't have a saturation more than 80%, there is a higher mortality in these kind of babies. And also the heart rate should be more than 100. So more and more evidence will come up when they will talk about babies who are 23, 24 weaker. Maybe they will require more than 30% FiO2 to begin with. But if we give too much, we all know that blindness can come, ROP will be increasing. What about the babies who are more than 35 weeks? Definitely you're going to start with the initial of 21% oxygen. However, if you're starting a baby with 100% oxygen, it is going to be causing more mortality. So don't do that. And you have to titrate. So you look at the saturations, what is happening at 5 minutes. And if it is not achieved, which is different for different gestation, then you can increase your FiO2 0.1, 0.1 every 30 seconds. Then comes the heart rate monitoring. So we have different ways of heart rate monitoring, starting from the umbilical cord holding and looking at the pulsations, to the stethoscope and looking at the heartbeats, and to the ECG. So if you compare, and that pulse oximeter. So definitely the pulse oximeter is better than the other two. But if you compare the pulse oximeter with the ECG in the first 2 minutes, definitely heart rate was able to be picked up better with the ECG. However, if you look at the clinical outcome, they were not much different between the two. So at least start with the pulse oximeter. Then the chest compression. So different things which were coming up were chest compression with sustained inflation. And there were piglet studies which were showing that if you do a sustained inflation with chest compression, it is going to be better. However, we don't have much data right now in the babies, but I just want to highlight on this so that you know that the next thing which is coming up might be this. What about sustained inflation as such? So systematic review for sustained inflation was done, which looked into giving sustained inflation of more than 1 second to not giving sustained inflation, and looking at the death before discharge, and death in the delivery room, air leaks, and requirement of mechanical ventilation, and so on and so forth. So after the 2015, there were 9 additional RCTs and so many babies were included, and they found that sustained inflation actually did not help. And the largest study which was done, SAIL trial, had actually to be stopped before because there were more deaths in the sustained inflation group. And hence it is recommended not to do sustained inflation during resuscitation greater than 5 seconds. What about adrenal administration? So adrenal, this is very important slide where you can see that there is a difference between a newborn and who's just born, whereas a baby who's in the postnatal ward. And if you give the adrenaline through the endotracheal tube, the first dose actually, the ROSC, return of the circulation, is in 40% in the newborns, whereas it is 50% in the postnatal baby. And second dose causes 66%, whereas 83% in the postnatal baby. And when you give IV epinephrine, it is 100% in both. And if you see if they look at the plasma level of the epinephrine, it is much more in the postnatal baby rather than the newborn. Why is it so? So we should look at signs. If a baby who is just born, you know that if you are injecting the endotracheal epinephrine, there is a lung which is filled with water, and the compliance of the lung is poor, and hence the absorption of the epinephrine is going to be poor. Again, there is a high PVR and low pulmonary blood flow. This will limit the further absorption. And then there is a right to left flow, which will also further decrease the absorption. And that's why epinephrine in the ET tube is not suggested in a newborn baby. Whereas if the baby is already in the NICU where the lungs is filled with air, so if you give an endotracheal epinephrine, it's going to get absorbed. The compliance is already better, so absorption is going to be better, and high pulmonary pressures are going to be there, which are reduced, and hence it is going to get absorbed better and better. So that's the difference. Another difference is of the doses. So the 0.01 mg per kg versus 0.03 mg per kg, there's a big difference. And if you see, the ROSC is achieved much more when you are giving a higher dose. And along with that, the flush also matters. So if you give a higher dose with higher flush, the ROSC is going to be achieved in 100% of the babies, whereas low dose and low flush, only 33% will achieve the ROSC. And the time to achieve the ROSC is also much lesser if you give higher dose with a high flush. So we should go for a higher dose with a high flush. This is just, I just took it because it came in PAS. This is not in human beings, it's in the animal study, but what they are trying to see to reduce more time, they are giving epinephrine directly to the cord. So they are giving epinephrine to the cord, and then they are milking the cord, and they found that the ROSC achieved was much faster when they were giving through the umbilical catheterization. So this is new thing which might come next time. So the vascular access should be umbilical vein, and if it is not available, you should go through the intraosseous route. Then what is happening to our meconium stained amniotic fluid? Endotracheal suction should be done or not? For tracheal suctioning, babies, in a vigorous baby, definitely not. In a non-vigorous baby, above 34 weeks or greater, they looked into whether you should suction or not. And they found they were looking at the survival to the hospital discharge and the neurodevelopmental impairment and meconium aspiration syndromes. And they found that when 2 studies before 2015 were there, they found that it much favors no suction. After 2015, more studies have come up, and there is actually no difference between the two. That's how it has come. So this is the no difference in mortality and no difference in need for resuscitation. But after this decision was taken in 2015 about not to suction the meconium stained amniotic fluid, when Vermont Export retrospectively saw the babies, and they found that when you are not suctioning, as when you are comparing before 2015, there was a higher need of nitric oxide, and there were more babies with moderate to severe hypoxic encephalopathy. So they had shown a sign of question if you should not suction or not. But still, when you go, systematic review was done, including all the studies, it did not find much difference. And hence, ILCOR said that we still suggest against the routine immediate direct laryngoscopy after delivery with or without tracheal suctioning when compared to immediate resuscitation without direct laryngoscopy. So this is out from the resuscitation trolley. And then they talked about, I think my colleague will be talking more on this, so I'm not going to talk on that. Skin to skin care, healthy newborn who do not require active resuscitation can be placed directly skin to skin on mom. That is, kangaroo mother care should be done, and it improves the temperature control, glucose stability, and breastfeeding. And we are doing this to our all-term babies. What about how much time should you resuscitate these babies when they are not improving? Earlier, we were using 10 minutes as cutoff, and we were saying if the baby did not come back to the ROSC, you should stop doing the resuscitation. The new guidelines in 2020, when they looked into the studies to see if 10 minutes is enough or you should give more time, and they had 5 observational studies, 16 eligible studies were there, and they found that if you are increasing the time of resuscitation to 20 minutes, it's not leading to increased impairment, and you have almost a similar results. And that's why they said that you can go to 20 minutes rather than 10 minutes to see if the ROSC is not achieved, and it did not affect the mortality or moderate to severe neurodevelopment impairment. So this is something new that, and I think everybody of us is taking 20 minutes at least before we say, okay, we cannot do anything more. So if no heart rate are there and all steps of resuscitation you perform well for 20 minutes, then healthcare team and the family can discuss to withhold the resuscitation effort. So you should bring the parents in between. So to summarize this, ventilation of the lung is the key to neonatal resuscitation. Increasing heart rate is the most important sign of effective resuscitation. Avoid cord milking in extremely preterm babies. 21% oxygen may not be adequate for initial resuscitation of extreme preterm, so you have to go higher, at least 30. Epinephrine should be avoided giving through ET tube. It should be given through the UVC, and you should go for a higher dose. And two thumb technique should be used for chest compression. Pulse oximeter should be used, and if required, you should go for the ECG. 21% for the term babies. PEEP should be used, and MR SOPA should be there for ineffective ventilation. So there was an, do I have time? 5 minutes more? So increased emphasis is given on teamwork, that you should prepare before resuscitation, structured check of equipment and supply, identify roles is important. And one person should be there for the birth of any kind of deliveries. And you should assign roles to different people who's going to do what. And if it is a high risk baby, then you should have more people coming in. And briefing, team briefing is very important to assign the roles, and ask the OB-GYN provider to for the delayed cord clamping. You should anticipate high risk delivery, so you should have chart which are the high risk delivery when you will ask more people to be there. And you should, equipment check should be done for all the equipments, and you can have a checklist like this so that you don't miss anything. And the team should be there, like the team leader, what is going to be there, who's going to be at the head end, one person who's going to be at the one side should be assigned for drying, stimulating, placing the pulse oximeter, assessing the heart rate and breathing, and doing the chest compression. The assistant should be there to start the ECG, helps the suction secretion, adequate thermometrist, and prepare medication and takes the note. And this one will be mainly for the airway. So if you look at the NRP 2015 and 20, the difference is antenatal counseling is a big role. Team briefing has come as a big role, which was not there earlier. Equipment check is a big role. And you have to ask, term gestation, good tone and breathe or crying. If yes, then stay with the mother for initial steps and routine care on ongoing evaluation. If no, then you have to warm, dry, stimulate, position, airway, suction if needed. Earlier it was warm and maintain normal temperature, position the airway, and clear secretion if needed, and dry and stimulate. So here dry came before that. So if the baby is having apnea, gasping, or heart rate is below 100, then you will come here. If no, then you will look at if the baby is having labored breathing or persistent cyanosis. If it is there, then you will position and clear the airway. You will look at the saturation monitor, give oxygen if required, and if required, you will put on CPAP. However, if the baby is apneic and gasping or heart rate is less than 100, you will straight away start the positive pressure ventilation. You will put a saturation monitor, you will consider ECG monitoring. And if the heart rate still remains below 100, you will start chest compression. And now you will try to actually intubate the baby, put the baby onto the cardiac monitor. And if the baby's heart rate is less than 60, you will start the chest compression, and you will coordinate with the PPV. 3:1 is the one which we will give. And if the heart rate remains less than 60, that is the time when you will consider that you will be giving epinephrine. So this is how you will go for the flow chart, and you will be monitoring your saturation targets with the time. So this is what you should have in your unit. Cleaning the airway is recommended for tactile stimulation and cleaning the airway in newly born infants. And recommendation for tactile stimulation and cleaning the airway in newly born with ineffective respiratory efforts is different. So you should not be doing any kind of cleaning if the baby is active. No suctioning should be done. But if there is an ineffective respiratory effort, that is the time when you will do the suctioning. And this is already told, meconium stained lichen, we do not do this routine endotracheal suctioning. Heart rate assessment, we already talked about. ECG leads are whenever you need a resuscitation, you have to be putting. Oxygen, we said we will start 20%, 21% for more than 35 weeks, less than 35, 21 to 30. And if baby has labored breathing, you will start the baby on the CPAP. You will start with 5 and you might increase depending on the baby. If the baby is not having good respiratory efforts and you are going to start positive pressure ventilation, then you should be giving a pressures of 20 to 25 and don't give a PEEP without the PEEP. So PEEP has to be given. So you should have a T-piece resuscitator or a bag with the PEEP should be there to give the positive pressure ventilation in these babies. And rate which you should use is 40 to 60. And the inspiratory time which you should use is 1 or less. And in the preterm babies, the routine use of sustained inflation should not be done because it may be harmful. Two-hand technique with jaw thrust should be the way to give this positive pressure ventilation. And PEEP, as I said, should always be provided to these preterm babies because we don't want collapse to happen. Now, after you have started the positive pressure ventilation, steps are clarified. First assessment should be done after 15 seconds of positive pressure ventilation. And if you see it is increasing, then you should announce heart rate is increasing, continue the positive pressure ventilation. And second heart rate assessment should be done after 15 seconds. However, if it is not increasing and chest is moving, then you will say heart rate is not increasing, chest is moving. And hence, you should continue positive pressure ventilation that moves the chest and assess after 15 seconds. However, if not increasing and chest is not increasing and chest not moving, so you will do MR SOPA, or you will intubate the baby, or you may go for LMA. And hence, after that, you will announce if chest is moving or not moving. So this is very important. And then you will assess the heart rate after 30 seconds of proper positive pressure ventilation that will make your chest to move. So MR SOPA is important. Mask adjustment, reapply the mask, consider the two-hand technique, reposition the airway place, head neutral or slightly extended. S is suction the mouth and nose. O is open the mouth with the lift the jaw thrust. P, increasing the pressure if it's not improving. And
Dr.
A
Kaushal.
is an alternate airway that you can intubate the baby.
Dr. Kaushal, we have only 2 minutes left.
Okay, I'm going to finish. And second assessment should be done after 30 seconds, where you should see that heart rate should be improving. And if it is improved, continue positive pressure ventilation for 40 to 60 breaths per minute until spontaneous efforts. If it is 60 to 90, you will reassess the ventilation and will do corrective measures. If less than 60, you will go for a chest compression. So chest compression, intravenous access, we have already talked about. Medication, we have talked about that we should go for a higher doses of adrenaline with higher thrush. And you should always have a post-resuscitation plan, which I think will be talked about by my second colleague. And this is my last slide, which is giving a crux to whatever you are doing, that the 4 pre-birth gestation questions, gestational age, amniotic fluid clear, additional risk factor. And I said umbilical cord management has come as the 4th one, not the single or twins. And then initial steps, warm, dry, stimulate, position, airway, suction if needed. If confirmed absence of heart rate after all appropriate steps performed, consider cessation of resuscitation after 20 minutes. When an alternative airway becomes necessary, a cardiac monitor is recommended for the most accurate assessment of the baby's heart. The suggested ET epinephrine dose, as I said, is higher and flush is higher. So suggested IV epinephrine dose is also higher than before and flush is higher. And flush IV epinephrine with 3 ml normal saline applies to all weights and gestational age. I think that finishes my talk, and there are more questions in the future which we will be talking about. And what is the volume resuscitation delivery room, volume ventilation in delivery room, large trials on ET suction in non-vigorous neonates born through meconium stained amniotic fluid. And I think in 2025, all these will be included and new guidelines will come up. I'm open for questions.
Thank you.
Thank you.
Thank you, Dr. Kaushal, for your excellent presentation. Unfortunately, we are very tight in timing. We won't take the questions at the moment. We're going to leave it until the end of the session, should time allow us. So,
great. So I will introduce the second speaker. Good afternoon. It's a pleasure to announce one of our colleagues, Dr. Hicham Mansour. Dr. Mansour is a pediatrician who is specialized in the inborn error of metabolism, neuromuscular diseases, and pediatric neurology at St. George Hospital University Medical Center. Dr. Mansour is an associate professor of clinical pediatrics at the Benemendov University. He is specialized in childhood disability specialist, and he is the president of the Neuropediatric Club for 8 years at the Lebanese Pediatric Society. And he is the current president and the founder of the Inborn Error of Metabolism at the Lebanese Society of Pediatrics. Dr. Mansour has a lot of research and publication. Dr. Mansour will be presenting today neonatal metabolic disorders in emergencies. Dr. Mansour.
Thank you, Dr. Hamod, for the kind presentation, and thank you for the society for inviting me to this beautiful meeting. I hope I won't bore you with these slides I have prepared. Usually the topic I will present is what we have all, me included, have skipped during our medical school. Sometimes we do not even have that chapter to study about during our preparations. So I will try to guide through a few steps just to remind you of these disorders. I divided my presentation into 3 parts. A small reminder of the groups of inborn errors of metabolism, since it's very essential to know what we are dealing with so that we can go through the management. I will speak a little bit about the clinical presentation of these disorders, and I will speak at the end about the key points to manage the emergencies and these diseases. Now, everyone is very skilled and very knowledgeable in identifying the type of shock that might present either to the emergency room or to the PICU or the NICU. You all know the types of shocks, you all know how to manage them, but the problem remains if you have a type of shock which is not responding to classical clinical management. And this, at this point of management, you are not supposed to doubt yourselves because you are following guidelines, you are doing everything correctly. But if this does not fit the appropriate guidelines, this means there's something that joins all these types of shocks, which is the missing part of the puzzle, which is the metabolic connection, which is a metabolic disease that can present with any kind of shock and sometimes parts of every shock, because we have an unusual behavior of the cells all over the body. So this is when we are supposed to think of something metabolic. So how do these metabolic patients present? These patients are healthy patients who most of the time are born with a symptom-free period that goes from hours to 2 weeks sometimes. And the symptoms they present with are usually very non-specific. These are term babies, healthy, from healthy parents, most of the time consanguineous, since you know very well that at our closed society, consanguinity rises to up to 70%. The parents, the mother will have a normal pregnancy, normal delivery, and sometimes few days up to few weeks without any symptom. And if we are lucky enough, the patient will have a secretion of specific body fluid or a specific order for body fluids. But this is not a rule for us to follow, so we are not supposed to wait for these signs to have a metabolic diagnosis. Now, in these patients, most of the time they deteriorate for no apparent reason, and they don't respond to our regular symptomatic therapy. And what is very peculiar is that the investigations in these patients are most of the time normal. Clinically, the symptoms can be everything in any organ. These patients can present with respiratory distress, with hypotonia, with poor suckling reflexes, with vomiting, diarrhea, dehydration, lethargy, seizures. Every kind of these symptoms can guide us to something metabolic if they don't respond to a regular anti-epileptic drug, or if we go through a regular dehydration management and we keep having an unusual negative molecule causing this acidosis, let's say, or if a child has a hypotonia and does not respond to regular sepsis management. So what are these disorders? These diseases individually, they are very rare, but collectively they are very, very common, especially in our population. Pre-symptomatic diagnosis is very possible. Sometimes it can help us prevent having another child having the same problem. The inheritance mode can be anything, everything, recessive, dominant, X-linked, sporadic, hereditary, and these patients can appear at any age from the fetal life up to the old age. Now, what will be interesting is to know what are the classes of these disorders. No one can remember the known 7,000 metabolic diseases. This does not fit with the human mind. So what is interesting will be to know with which category of these disorders are we dealing, so that we can start managing while we have the diagnosis. Many classifications are present. A new one is now being described based on the organelles in the cell, but I will go through the clinical description, the classification of these disorders, which will guide us better through the management. So we have the intoxication group, which is the first group, the energy metabolism defect, which is the second group, and the complex molecules, which are the third group. For the first group, to simplify, here we have a molecule A, which is not metabolized into a molecule B because of an enzyme, of a mutation causing this enzyme block. So the patient will be intoxicated by the accumulation of the molecule A. Here we'll have the acute intoxication and the chronic intoxication. Here I'm including the amino acids, organic acids, urea cycle defects, and the sugar metabolism defects. In these patients, an excessive amount of protein will cause the acidosis, while in the sugar patients, an excessive sugar or metal will cause the decompensation. These patients are bound to have symptoms due to the accumulation of the ammonia molecule or the bicarb molecule. It will cause either the acute or the chronic symptom. Clinically, these patients, as I said, will have a regular normal delivery, symptom-free period, and then they will come in a septic-like presentation, vomiting, having diarrhea, having liver failure. Chronically, they will have failure to thrive and delay and sometimes cardiomyopathy. In these patients, any kind of fever, any kind of catabolism, sometimes an increase in the protein intake will cause these patients to have acidosis and hyperammonemia. And this is where we are supposed to act to correct these toxic compounds from the body. First, by stopping the amino acid intake and giving a special mixture and removing the compound which is intoxicating the body. So the key management to the first group would be to stop the aggressing agent, most of the time it is the milk, and then to remove the toxic compound and to avoid any catabolic decompensation. And this is one of the rare cases where we don't advise to have breastfeeding. Now for the second group, those are the patients who have energy metabolism defect, which means the molecule A is not metabolized into the molecule B, but the molecule B is the ATP. So I'm in front of two problems, the ATP which is not present and the A which is accumulating. So this will cause a deficiency in energy production. It will affect the muscles, the liver, the brain, and the myocardium. Now here we have many disorders. The most common in Lebanon are the mitochondrial diseases. We have all the statistics showing that. And the cytoplasmic problems are the glycogen storage disease. Now, if we are going to remember every disease by itself, it won't be something easy, but we can remember the common presentation of these patients. They all just thrive for glucose. They will have hypoglycemias, generalized hypotonias, hepatomegaly, increased lactic acid, failure to thrive, myopathy with a relevant increase of CPK, a cardiomyopathy, and an increase in uric acid. And most of these patients are suspected of having SIDS. So in these patients, I'm supposed to have enough sugar for the patients who have hypoglycemia. I'm supposed to correct the hyperlactic acidemia and to prevent any kidney shutdown by the huge CPK. So remember, be generous with your sugar in these patients who present with severe hypotonia where you suspect a second group. In these cases also, a simple febrile illness can cause this regression, and sometimes we overlook our hypoglycemia and we fail to give enough caloric supplements. And here I'm giving you two examples of how these patients can progress just by the hypoglycemia, or the acidosis. Here is a patient who has a glycogen storage disease, who had repeated episodes of glycemia below 40. Lesions like those are very common in these patients, and they are preventable. While in the patients who have lactic acidosis, we are supposed always to avoid having a huge lactate amount in the body because it will cause an end-circulation vasoconstriction. It will be like a pseudo-stroke, which will cause basal ganglia lesions and a huge accumulation of lactate found on the spectroscopy. Now, the key management to these patients would be to remove the intoxicating compounds, which is the ammonia, the acid, the CPK, and the uric acid, and always remember, be generous with your sugar. Don't be afraid to give these patients sugar, and protect the kidneys, the heart, and the central nervous system. Now, the third group is the least presenting with acute episodes. Those are the complex molecules groups. These patients have big molecules which are not able to metabolize. The symptoms are present there to stay there. Here I'm speaking about lysosomal storage disorders, peroxisomal storage diseases, congenital disorder of glycosylation, and cholesterol synthesis defects, mucopolysaccharidosis, Tay-Sachs, Sandhoff. Almost none of these disorders is yet treatable, but bone marrow transplantation and enzyme cell therapy has been tried in these patients. Currently, we know that Pompe's disease, MPS 1, 2, 3, 6, 7, and Fabry disease, and CLN, and Gaucher disease are treatable. So here the emergency relies in the identification of these disorders before going through the management. Now, before I go through the emergency management, I would like to give you a small idea how these disorders are distributed in our country, because every one of you knows very well his surroundings, and you are supposed to know what are the common disorders in your area. It will help you a lot finding these disorders. So mitochondrial diseases are distributed everywhere in Lebanon. We don't have any predilection. We have even our own mutations, the PET100, which is the Lebanese mutation. So if you have something unexplainable with acidosis, lactic acidosis, think of mitochondrial diseases. We are now finding the mutations confirming this study. PKU patients are found in the area of Dunia, Hermel, and very far in our south. Tyrosinemia type 1 are found mainly in the surroundings of Sur. The patients with the branched chain aminoacidemias are found around the area of Baalbek and in the south. Glutamic acidurias mainly in the Shuf area, as well as caravan diseases. Well, now for the lysosomal storage disorders and the group 3 disorders, we have CDG patients in the area of the Shuf. We have the patients with Pompe's disease in the Shuf and in the north, mucopolysaccharidosis in the areas of the north and of Hermel and of the south. Now, having this small scheme in your head will help you identify these disorders. Now, if we are going to go practically through the management of these disorders, just keep in mind you have these 3 groups. If you have a patient presenting with a shock that does not fit all these known shocks, you are dealing with either group 1 or group 2. In this case, it's the patient presenting with a life-threatening decompensation, acute decompensation, sometimes neurological distress, and this is how you are supposed to orient your management. While if the patient presents with unusual cardiac manifestations, dermat manifestations, neuromuscular, which do not fit into a regular infectious or immune or autoimmune disease, here you are supposed to think of something in the third group, which is someone who presents just for a regular follow-up. So in the first 2 groups, you are dealing with the patients mainly in the neonatal or pediatric period, coming in shock, while in the third group, patients are older patients with non-specific symptoms. So in this case, I will try just to go rapidly through the management, emergency management of patients who have these kinds of diseases. The 4 points we are supposed to consider are the acidosis, hyperammonemia, hypoglycemia, epilepsy, and of course, an appropriate diagnosis. Because in the acute emergency, the patient is coming with a neurological distress. It's very important to classify the group of the patient to avoid giving a wrong diagnosis that can be sometimes lethal. In these patients, in front of a neonate with unexplained shock, you are doing your regular reanimation. Everything is going on step by step, Meanwhile, you are supposed to go through the metabolic workup and to deal with the possible decompensation of a diagnosis that might appear after 2 weeks sometimes, not immediately. So here you are supposed to remember that we have some precious samples, the blood, the urine, and the CSF, and a dry Guthrie paper. If a patient starts with these symptoms, before you go through this management, take this Guthrie paper on the side, because you know in our society, not everyone can pay immediately the money for amino acids, organic acids, and the very expensive workups. So you are supposed to go and start your management, and sometimes it might hide your diagnosis. So keep on the side a small tube of blood, a small tube of CSF, some urine, and this Guthrie paper, which can be very helpful even if you start your management, because when you start your IV treatment, you might easily mask the diagnosis. Now, what is the essential workup in a patient who presents in a sepsis-like presentation, severe hypotonia, and does not fit these diagnoses? You are suspecting something metabolic. Take a small sample of electrolytes with bicarb, with ammonia level, glucose, lactate, pyruvate, and calcium. We don't have currently the ketone bodies, but we all are always supposed to remember to measure the CPK, of course, a CBC, and keep on the side a small urine sample. Now, what are the first step in the management? You have this patient presenting with unexplained acidosis, unexplained hyperammonemia. The first thing to do is to stop the protein and lipid intake for at least 48 hours. Keep him on IV glucose 10% maintenance. If you want to go higher, and immediately start by treating the acidosis and the ammonia. And of course, remember, never keep a child without proteins more than 2 days, because he will go through catabolism and he will start regressing. So we are supposed always to remember to start 0.2 gram per kilogram per day of proteins after 48 hours of stopping them in a patient where you are suspecting to have a metabolic disorder. And then you treat according to the diagnosis, which is most common. We are supposed always to monitor the electrolytes, the glucose, the lactate, the CPK, the acid-base status, and always keep the sodium above 135, because brain edema can easily occur in these patients because they are overloaded with organic molecules. And be careful for beta-oxidation cycle defects, because in these patients, IV lipids are lethal. So always measure the CPK. A child who has very high CPK during his distress is most likely a patient who has a mitochondrial or a beta-oxidation cycle defect. So we are not allowed to give him any IV lipids. Now, how do we manage the patients who have hypoglycemia, either in glycogen storage disease or other hypoglycemic disorders? We are allowed to give glucose bolus gifts to be given immediately in 10 minutes IV. Now, to have a small rule of thumb so that you don't have to calculate immediately. In a child who has a glucose below 40, from 0 to 12 months, you are allowed to give a glucose gift of 500 milligram per kilo. From 1 year to 6 years, 400 milligram per kilo of glucose. From 6 to 12 years, 300 milligram per kilo of glucose. And in adults, 250 milligrams per kilograms of glucose. Meanwhile, you are correcting your acidosis through the regular formula of 0.3 times weight times the correctional amount of correction, which should never exceed 10 milliequivalents. And usually we give half of the quantity over 3 hours and the other half over the following 24 hours. Now, we have many other disorders that need to be given enough sugar. You don't have always the appropriate diagnosis at the first steps of the disease. So you can rely easily on these gifts of bolus of sugar until you have an appropriate diagnosis for your disorder, and then you sometimes can give enough glucose with sometimes insulin to maintain a stable anabolic state in these patients. Now, what are the medications you are supposed to keep in mind for these patients, mainly when you have the most scary form, which is the hyperammonemia. Now, hyperammonemia is usually...
Last 2 minutes.
Okay, I'll go very fast. So in the patient who have hyperammonemia, in neonates, above 200 is hyperammonemia. In younger patients above 90, we are supposed to stop protein intake, give enough glucose, and correct electrolytes, and always start sodium benzoate. Don't be afraid to start 100 to 250 milligram per kilo per day divided in 3 doses. Carnitine would be very helpful to remove ammonia, 100 milligram per kilo per day. You all have read about lactulose and metronidazole, but it takes enough time to work. The patient might deteriorate and decompensate a lot, while giving sodium benzoate will help you in within a few hours, and it will save the life of the patient. And remember, in hyperammonemia, if you see such image, it can be due just to hyperammonemia, not to an infection. So don't go treating an infection if you have an ammonia of 180 with this kind of hyper signal on the MRI. For lactic acidosis, we are supposed to treat the cause, and of course the management of the acidosis will be correction by 0.5 times weight times the milli-equivalent correction, and always add carnitine. While in the case of epilepsies, we are supposed to treat the cause of the epilepsy. I will just give you a small idea about the medication are supposed to be available. Pyridoxine, folinic acid, and pyridoxal are supposed to be available in these cases. For the breastfeeding emergencies, remember, if you have a liver dysfunction, galactosemia, stop breastfeeding. Hyperammonemia, it's a group 1, stop breastfeeding for 48 hours. In patients with hypoglycemia, high CPK, you can keep feeding, which is adapted. And if you have an epilepsy without acidosis, without hyperammonemia, you can keep regular feeding. So just keep in mind, for the first group, stop aggressing agent, mainly proteins, lipids, remove toxic compounds, and avoid catabolic decompensation. For the second group, always be generous in giving your glucose. And for the epilepsies, if you have a neonatal encephalopathy, always avoid hypoglycemia, and please don't give any valproic acid. Preferably go for levetiracetam and benzodiazepines. Don't go too much for phenobarbital. The effects after a few months will be very deleterious. If you have pyridoxine, folinic acid available, you can use it, and we can sometimes suggest ketogenic diet and GLUT1 deficiency. Thank you.
Thank you, Dr. Mansour, for your nice presentation. We will not have questions because we were late. Any questions that you would like to give to Dr. Mansour, please use the Q&A session, and he will be more than happy to answer you. We move to the next speaker.
Okay. Our next session will be presented by Dr. Lama Charafeddine. So it will be about children born too soon and the management in the first golden hour and beyond. It's a pleasure to present you Dr. Charafeddine, who is an associate professor of clinical pediatrics and neonatology at the AUB. She is also a diplomate of the American Board of Pediatrics and Neonatal Perinatal Medicine, a certified professional in NID, CAP, and regional trainer in Neonatal Resuscitation Program and NRP since 2005. She is also a UNICEF regional consultant for the early child development and has served as a technical advisor for the WHO. Her work revolves around the perinatal and neonatal health, development care, and ultra-early intervention, the early child development, and development assessments and outcome of premature infants. You are welcome, Dr. Charafeddine. Go ahead, please.
Thank you very much for the introduction. I'm going to have to tell you that my talk is, Dr. Faouzi Maalouf is going to start because we split the talk in two. He will be talking about extreme prematurity and the born too soon part of the talk, and I will continue with the golden hour. So without further ado, I think somebody else is going to introduce Faouzi, and then I will take over after that.
Okay, it will be Dr. Boulos.
Yes. Good evening, everyone. It's my pleasure to introduce Dr. Faouzi Hicham Maalouf, who is graduated from American University of Beirut. He did his pediatric residency at University of Arizona in Tucson, USA, and his fellowship in neonatology at Vanderbilt University, Nashville, USA. Currently, he is Assistant Professor of Pediatrics in the Department of Pediatrics and Adolescent Medicine, Division of Neonatology. He is going to talk about born too soon, golden hour and beyond. Dr. Maalouf, the floor is yours.
Thank you, Dr. Boulos, for the kind introduction. Let me just share my screen. Okay, so hopefully you can all see my screen. So as you have mentioned, so this session will be in two parts. I will be talking about what happens or what we should think about when we're expecting a baby who will be born extremely premature. So I will be talking about the counseling component, and then Dr. Charafeddine will take it and talk about what happens in the first few hours of life, especially the first hour of life after these babies are born. So it is not a surprise to most of the audience that prematurity is a major component of what we do in our daily life. It is we know that 10 to 12% of babies who are born premature, so before their 37 weeks of gestation. And we know that prematurity alone is a major component of death in the infant period, and especially in the neonatal period, where about 1/3 of those deaths are due to prematurity. However, we've seen a lot of improvement in terms of survival for those babies, especially for those at the limits of viability in the last 10 to 20 years, which brings us to the definition. So fetal viability by itself technically is the ability for the fetus to live in the extrauterine environment. But we know that for this to happen, babies require a lot of support, a lot of intensive care. It can be respiratory support, cardiovascular support, and they require to be in the NICU for a long time. So when it comes to viability, we need to remember that one of the last organs to mature in an embryo and then in a fetus is the lung. And the lung is the main reason why babies might make it or not. And we need to remember that lung maturation goes into 5 different stages. What we're worried about are the 3rd and the 4th stages, which are the canalicular and the saccular stages. And this is the time where the lung can actually work as a lung and we can have gas exchange. And this is when we lay the foundations for the alveoli to start growing and developing. So just a reminder, babies that we're talking about, so specifically those born less than 28 weeks of gestation, are usually in the end of the canalicular stage, early saccular stage. And this is a region which is circled here around 24 to 25 weeks of gestation. And that's why historically, when we say, will babies make it? This is the time when we say, okay, at 24, 25 weeks is when we see babies making it. Anything before that, that is not really promising. However, we always see surprises in medicine. And as you can see from this image from the BBC News, this was in 2017, you see a happy mother holding her twins. And the title is "The Twins That Are Born at 23 Weeks Are Little Miracles." And just to remember that this is what our parents would be seeing. So this is what would be placed on in the news media or even on social media. And so our parents, especially those who are expecting premature babies, are under the impression that these babies do survive. And there's a lot of reason for why they say that. So whenever we want to go and counsel and consult these parents, we need to factor in these things and to know what they know prior to going. So when it comes to counseling parents who are expecting a baby at the limits of viability, there are 4 different scenarios or things that we need to keep in mind. Well, first of all, we know that these babies can be an ethical dilemma because there are different factors that I will be talking about in the next couple of slides. Be it, is it the right thing to do or not? Do we do everything for those babies who might not make it or not? And then one weapon that we have to keep in mind is we need to be very comfortable with our numbers. We need to know what happens to those babies in terms of survival. How many of those will make it past the NICU? How many of those will make it past their first year of life or even into childhood? So this is very important. And we also have to factor in that even if those babies make it, we need to know what the morbidities are for those babies. So what will happen to those babies? What kind of quality of life are we expecting? Especially that we know that these babies have a high chance of having bronchopulmonary dysplasia, retinopathy prematurity, or even cerebral palsy. And these are 3 main reasons where the quality of life is major factor. And the last thing to keep in mind when talking to parents is to understand that prematurity by itself can be a social stressor. It creates a lot of stress on families. We've seen many families who have had separation or divorce because of having a baby in the NICU for a long time. We know that those babies who are in the NICU tend to take a lot of resources. So let's say it's a family that has other kids. Now, for a few months, all the attention is going towards the baby who's in the NICU. So this is something that we need to keep in mind. And I will not talk about that a lot later on. So when we talk to families, there are two approaches that have always been the mainstay of medicine. The older way used to be the paternalistic approach, which we see on the left. In this approach, the physician brings their expertise. They basically make the decision for the parents whether to resuscitate a baby or not, based on their clinical judgment and what they've seen in the past. Now, this is the older way. Families nowadays don't usually appreciate this mode, and I agree with that. So we end up going more towards a shared decision-making kind of approach. In this sense, the physician brings their own expertise and experience from what they've seen in the past, from all their knowledge that they have, and then they factor in the parents' values, their religious beliefs, what they want to do, what are their preferences, and then they try to come with a sort of compromise which would benefit both parties, especially keeping the baby in mind as a primary outcome. So when it comes to the ethical dilemmas, out of the four pillars of ethical dilemmas in medicine, we need to factor in autonomy, which is the parent has the right to choose what to do with their own body. Now, in this situation, the patient is the baby or unborn baby who doesn't have the privilege of making their own decisions. So the surrogates are the parents, mostly the mother, because sometimes the father is not available. So here we have a conflict between the autonomy. So the parents want to do everything for the baby. But on the other hand, as physicians, we need to also factor in that we need to do the right thing or think about beneficence. And sometimes the right thing to do for many babies, especially those with a dismal chance of survival, are sometimes not to do anything at all. So when it comes to the baby, this baby who will be born very soon has two options. We either do everything, it can be chest compressions, intubation, do a lot of resuscitation, and this baby will face probably a longer time in the NICU, which can be months with all the stressors and financial burden that has, but there will be a chance of survival, although the outcome is not really known. But this also carries some risks of what kind of quality of life we're thinking, versus a baby who is really, really premature. We're talking 22, 23 weeks, where sometimes we elect for us to do the best thing is actually not doing anything and have this baby being held with their parents for a few minutes or hours and cherish this precious moment until the baby dies. So this is basically the ethical dilemma that we think about when we're dealing with this situation. Now, in terms of numbers, I'll just briefly go through what are the expectations for babies born extremely premature. Now, this is old from 1993. This was published in the New England Journal of Medicine. It shows that there was decent survival for babies born at 25 weeks of gestation, where their survival to 6 months of life lies around 80%. It's a little worse for those babies born at 24, where the survival used to be around 55 to 60%. Now, there's a big gap when it comes to 23 and 22 weeks of gestation, where the survival was at best about 15 or 16%. And this is the reason why historically we haven't been really enthusiastic of resuscitating babies less than 24 weeks of gestation. But as always, we're always surprised with new data, and this is one of the recent ones. This was an article which was in the New York Times, and it's referring to an article in the New England Journal of Medicine, which shows that actually if we give those babies a chance, especially those at 22 and 23 weeks, they do have a chance of survival, and regardless of what quality of life we're talking about. But as I said before, the families are looking at these articles and thinking for themselves that maybe, okay, if I'm presenting at 22 weeks, then my baby has a chance of living. So we have to take things with grains of salt. And so here, as you see, there's a very happy child. She's 5 years old and she was born 22 weeks. And this refers to really, if we cannot just judge if the baby will make it or not based on the evidence or the literature, we actually have to also factor in what to do about it. So in this chart here, you can see that there's basically a consensus. So this is a chart looking at survival in different neonatal networks across the world. And we see that for babies who are at 24 and 25 weeks of gestation, so at 24 and 25 weeks of gestation, there's kind of a consensus among the world of which babies are making it and not. So we see this decent survival reaching up to 85% for those babies. However, when it comes to 23 weeks, there's a discrepancy between different centers. So places such as Japan in the dark blue really do well and mostly because they offer resuscitation more frequently than others. And other places such as the European systems where they don't offer resuscitation for those babies, you don't see that much survival. But what's surprising is for 22-week babies in places such as Japan, where they're really meticulous and they do everything they can, you see decent survival up around 40%. However, we know that the majority of those babies, we're talking about 70–80% of those, have neurodevelopmental impairments later on. So for some families, this might not be what they're looking for, and they need to know that ahead of time. Just to share some information about what we have locally. So this is information from our center at AUBMC. And you can see that for babies who are born at less than 26 weeks of gestation, our survival in the past 10 years has been around 40%, 38%. And we've seen a lot of improvement in the last 3 years, which has risen to 65% or 64%. And this is really promising because we have changed the way we practice. And this is something that Dr. Charafeddine will be talking about more in more details, especially what happens in the first few hours of life. And what's interesting here to see with our numbers is that our numbers are comparable to what we see in the world. So we are doing the right thing in a way, given all the limitations of resources, especially what we see nowadays with the limited care. Now, I just wanted to introduce a couple of tools that would be helpful for you when you are going to talk to those parents. One of them is the NICHD calculator. And so this is an interesting calculator, and you can access it through the link you can see on the bottom right. So this website, this NICHD calculator looks at all numbers of babies in this network, thousands of babies who are born extremely premature. And it factors in what happens if, depending on the gestational age, the weight or expected weight, the baby's sex, and whether they've received steroids or not. So just for fun, I plotted in a baby who was born at 24 weeks with an estimated weight of 600 grams. This is a male infant. And you can see that survival for this baby is around 55%, which is decent. But when we just change one thing and go from male to female, you can see how this survival jumps drastically to 68%. And this jump from 10–15% makes a big difference in families' lives. So I would urge you, before going to talk to parents, have some sort of a model where you can go access it and see what are the real expectations. And you should modify this toward the center where you're working, depending on your criteria. Another tool to keep in mind is this nice visual that parents usually love to see. So when you talk to parents, it's nice to have some sort of a visual to know what are the expectations for their baby, especially if they're going to the NICU. Parents really like to know numbers. They need to know what are their survival rates, but instead of just giving them percentages, it's nice to show them something such as an icon array where they can see how their baby will do compared to others. And you can just plot 100 babies, and they will see that here the vast majority of babies don't make it for 22 weeks, but when it comes to 25 weeks, the vast majority will make it and do fine. And here you can see the long-term disabilities. What do we mean by bronchopulmonary dysplasia? What do we mean by IVH, and so on and so forth? It's nice for them to have a visual. So just to wrap things up, I just here will show you 3 hypothetical cases. I think we will have a consensus for babies born at 24 weeks of gestation for a younger mother. This is her first baby with preterm labor. Most of physicians nowadays would opt to resuscitate if their center allows them to do so, especially if they have the equipment to do so. But when it comes to 22 weeks, there's a lot of discrepancy. A lot of physicians would opt to not to do anything, whereas some would do. And we know that there are numbers to support doing something for those babies. But when it comes to special situations, let's say it's an older mother, she's had multiple abortions, this is her last chance of having a baby, and she's presenting at 22 weeks. Would you offer resuscitation or not? And hopefully from this brief talk that I showed you, we have enough data to show us that there is a possibility that this baby will make it with a decent kind of life, but it all depends on what happens after they're born. So this will be a nice segue to Dr. Charafeddine to continue and tell us what happens after these babies are born.
Thank you, Faouzi. I will share my slides. Thank you, Faouzi, for this very nice introduction to what I'm going to share with you. Do you see my slides?
Yes.
Yes. Okay. So after Faouzi has introduced the dilemma of extremely preterm babies, what I would like to share with you is what do we do with these babies, and what is the ideal, what should happen in the golden hour? So this is the roadmap of the talk. In the next 15 minutes, I'll talk about the concept of golden hour, what are the components, and then how it has been applied. So the concept, the term has been adapted from adult trauma, where they found that adults who presented to emergency room and who were treated within the first hour did much better in terms of survival. For neonates, this term was developed by Reynolds in 2009. Basically, it's a practice that focuses on minimizing neonatal complications using evidence-based interventions and treatments to improve outcomes. Now, Dr. Faouzi and Dr. Kaushal made my life much easier to go through this. First, in terms of counseling, Faouzi has discussed amply this topic. It's extremely important to do the counseling before going to the resuscitation of those babies. I'm not going to discuss that. And like Dr. Kaushal mentioned, this is now emphasized on the neonatal resuscitation algorithm. It's a big part of it. The second thing that's extremely important in anticipation for birth of extremely preterm baby is the preparation of the NICU and preparation of the team. And most importantly, having a team briefing, which is also part of the neonatal resuscitation algorithm here. And what do I mean by team briefing? Meaning role assignments, knowing who's going to do what. And most importantly, also collaborating with our colleagues from OB and anesthesia to know the management in terms of anesthesia for the mother, whether it's a general anesthesia or spinal, and with the OB team to ask about the umbilical cord management. And Dr. Kaushal mentioned this previously, the importance of delaying cord clamping. I'm not going to dwell much into it, but this is part of the golden hour. I'm not going to talk about the resuscitation of extremely preterm, but I'm going to talk in the first hour, and the resuscitation is part of that first hour. So cord clamping, why is it important? It's because, the placenta contains about 30 ml per kilo. And if we allow this blood to go to the baby while the baby is initiating breathing, this will improve cardiac output and pulmonary perfusion. And it has been shown, like Dr. Kaushal mentioned, it has been shown or proven to be beneficial for stable term and preterm infants. I'm not going to talk about term infants, but I will talk about preterm infants. We know we have evidence from multiple studies and random and systematic reviews that delayed cord clamping in preterm infants reduces the risk of anemia, IVH, and NEC. It also improves survival overall, not only for those who are less than 37 weeks, but also those who are less than 28 weeks. And this first plot depicts that very nicely. And not only it decreases mortality, but also it decreases the risk of IVH for those who are, for all grades IVH. Umbilical cord milking, like Dr. Kaushal mentioned, is really not recommended. It was thought that it was a good thing to do. However, like she mentioned rightly so, this trial looking at umbilical cord milking comparing to delayed cord clamping for babies who were less than 38 weeks had to be stopped in the middle before enrolling all the patients, because there was significant morbidity in the babies who were 23 to 27 weeks. Therefore, umbilical cord milking is not recommended. Now, what about thermal protection? That's the third component of our golden hour. And I don't need to preach to this audience that the hypothermia is very common in extremely preterm babies, and they do lose a lot of heat because of all of the reasons I mentioned here. And you all know that admission temperature is a strong predictor of mortality, because we know with each degree Celsius decrease in temperature on admission, there is 28% increase in mortality and 11% increase in late onset sepsis. And in terms of long-term outcome, this retrospective study showed us that not severe hypothermia, but even moderate hypothermia will affect those babies. Those who have moderate hypothermia have higher risk of having low UPGAR score, more RDS, more mortality, more grade 3 and 4 IVH, and more NEC. Therefore, thermal regulation is extremely important. Now, how do we do it? This meta-analysis looked at ways to prevent hypothermia for preterm babies, and it included 25 studies looking at different modalities of preventing hypothermia, from barriers to applying heat sources to combining those interventions. And this systematic review tells us that using plastic wraps or bags do help. You have fewer hypothermia with the application of these. Applying an external heat source also helps. However, when you combine both of them, there is no difference whether you do thermal mattress or plastic wrap, but you have higher risk of hyperthermia if you do both of them. And each center will have to pick and choose what is more feasible and what is more logical at their places. At our place, for example, we use more plastic bags rather than wraps. Moving on to the fourth point of the golden hour is respiratory support. Again, Dr. Kaushal made my life easy by mentioning in the neonatal resuscitation algorithm that the most important thing for babies is to establish breathing, but for extremely preterm also, it is important to establish the FRC in the least invasive manner. And now we know that we can do that immediately in the delivery room, applying CPAP or non-invasive ventilation. She also mentioned sustained inflation. I'll talk a little bit about it. And last point is surfactant. When do we give it? How do we give it? And I'll talk briefly about that. And if we give it, it has to be within the first hour. So the least invasive way of using CPAP, we cannot talk about it without mentioning this landmark trial, the support trial, that informed us that we can treat extremely preterm babies with CPAP immediately in the delivery room without intubation immediately, without giving them surfactant, because it showed that infants who were treated with CPAP required less intubation and steroids for BPD and required less days on ventilation. So we could save about 50% of babies from being intubated if we apply immediate CPAP. And this meta-analysis confirmed that. This is a more recent meta-analysis confirming that CPAP is associated with lower risk of treatment failure, lower use of ventilation, lower mortality. However, if we don't pay attention to the pressure, there is increased risk of pneumothorax. Now, this has the sustained inflation question, like Dr. Kaushal mentioned, initially it made sense to use it because it will increase your FRC. However, for preterm babies, this meta-analysis showed that there was no difference whether you use sustained inflation or not in terms of BPD or death. And the more recent, the largest RCT looking at this question for extremely preterm babies less than 26 weeks had to be halted prematurely because there were excess death or early death in the first 48 hours for babies who were in the arm of the sustained inflation. Therefore, sustained inflation is not recommended for extremely preterm babies. Now, targeted oxygen, avoiding hyperoxia, also it's extremely important because like Dr. Kaushal, like I said, she mentioned all of these studied before, but I'll reiterate this meta-analysis looking at what is the perfect FiO2, if you will, for preterm babies. And it turns out that whether you use FiO2 of 40% or more than 40%, there is no difference on mortality. However, there's one trial that informed us that using room air will increase mortality. Therefore, the recommendation for resuscitation is to start with 30% until we know better. And obviously to target your oxygen to your oxygen saturation. Now, what if this baby, let's say we all know that most babies 24, 25 weeks end up being intubated, and after intubation, what are the things that we need to pay attention to in the golden hour? Obviously, avoiding high PIP, avoiding high tidal volumes, using a T-piece or a mechanical ventilation to have a constant PIP rather than a self-inflating bag where you can variably increase your pressure without knowing it. And then doing surfactant as early as possible, and I'll show you why. And maybe using the technique Ensure or other least invasive ways of delivering surfactant. So the early versus delayed selective surfactant, this informed us, this meta-analysis of 6 trials informed us that really, if the baby is intubated, the sooner you give surfactant, the better, because it is associated with less mortality. So this forest plot favors giving surfactant as early as possible. This other trial looking at whether to do Ensure or CPAP, and then if the baby needs intubation, intubate, favored more doing the Ensure technique, meaning intubate, give surfactant, extubate within the hour. And this is the outcome for this was chronic lung disease or death. Therefore, nowadays, most centers in developed country opt for doing the Ensure, and actually the most recent Canadian guidelines for surfactant administration is advocating for using this technique. Moving on to cardiovascular support, after you moved to the unit, within the golden hour, babies should be monitored obviously very closely for their heart rate and lactate. Those are signs of cardiac output. Placing a UA line is very helpful for invasive monitoring and for blood withdrawal. Placing a peripheral IV sometimes is needed to avoid hypoglycemia if there is one. Otherwise, we do place a UV line right away and do fluid resuscitation as indicated. And all of these, if they are done within the first hour, this will improve the outcome, and show you that why in a minute. Before we move on, another point is extremely important, is to start TPN as soon as possible. And why is that? That's because we know from multiple studies, and this meta-analysis shows that if we use very early on from day one amino acids, this will improve outcome for extremely preterm babies in terms of weight, length, and head circumference. And this study, although it is a retrospective study, but it shows very nicely that babies who received early parenteral amino acid had not only shorter length of stay and less chronic lung disease, but also at 2 years, they had higher language and motor scores. Beyond nutrition, the seventh point is preventing infection and doing other things, little things that will help those babies. Obviously, strict aseptic techniques in handling the baby, wearing gloves, it helps to have a central line bundle to avoid central line infections, starting ampicillin and gentamicin if indicated, because not all babies are born prematurely because of infection. Many of them are born for maternal reasons, and they really do not need antibiotics. And we know that antibiotics are associated with higher risk of NEC. Keeping them after we finish from setting up the respirator and the lines and the monitoring, closing the incubator and putting them in 80% humidifier, handling minimally, clustering care, putting headline. There is some evidence that putting the head in the midline prevents IVH. Obviously, when putting the line, we're gonna take the labs that are necessary, and then we're gonna monitor everything and document everything after we finish. And then 2 important things before we finish our golden hour is to communicate with the family, tell them, update them on the situation, allow them to visit, allow them to take photos, and most importantly, encourage mothers to start expressing breast milk. I cannot emphasize enough how important that is for extremely preterm babies. And after that, team debriefing is very, very important, because it allows us to review what we have done. even if we have done things in the right way, there's always room for improvement. There's always something that we may have done better or in a different way, and always review the areas that identify the areas that could be improved. Now, moving on to the implementation studies, there are a few of those. I'm not going to talk about all of them, but all of them are quality improvement studies, and all of them have shown that that golden hour can be implemented, it is doable. And if it is done, it is associated with better outcomes in terms of less time to initiating TPN, less time to giving surfactant, ultimately less chronic lung disease and less ROP in those babies. And then other quality improvement studies have shown that there was decreased RVH, decreased hypoglycemia. And this most recent quality improvement for the golden hour implementation of babies less than 27 weeks showed improvements in hypothermia, hypoglycemia, and minutes to completion of stabilization. What these people have used, most people use like checklists, such as this one, and I'm happy to share it with you. I mean, I'm not gonna go over it obviously, but it helps a lot to the team to kind of go over the things in terms of briefing, preparation, and then debriefing afterwards. This is another one showing a sample of team roles, each one, who is the team, what they're gonna do at what time, before delivery, after delivery, and then during the golden hour. And with that, I will leave you with my take-home messages that key to management of extremely preterm babies is family counseling is extremely important, even individualizing decisions, making shared decisions. The golden hour concept has many components, as you have seen. Many of them are derived from the resuscitation principles. Implementation of golden hour aims to improve outcome. It is feasible. Anticipation and briefing are essential for successful resuscitation and later on management of these babies. Having a checklist helps. And those few studies that I shared with you on the implementation of golden hour have all shown positive results. None of them have shown any negative outcome. And with that, I leave you with a picture of one of our 26-week babies who's, with the permission of her parents, I show you her picture. She is now 18 months and doing very well. And thank you.
Thank you, Dr. Charafeddine. Very interesting presentation. So we have one question in the box, and we will pass directly for the next session, I think, for the limitation of time.
Do we use sedation? No, we don't.
Any other question?
Je présente.
I have a comment, if you don't mind.
Yes, go ahead.
I thank you, Dr. Lamia, for the presentation. I totally disagree with saying that the surfactant should be given as early as possible. The second is also, I disagree with not giving sedation for intubation. Surfactant is not an emergency medication. Surfactant should be given only after achieving functional residual capacity, because there are three forces driving surfactant in: spontaneous, negative suction in, and positive suction out, and capillary diffusion. The most important is the suction in that distribute the surfactant uniformly through the lung, and that should be achieved after achieving functional residual capacity. I highly discourage people of giving surfactant in the labor room. I only discourage people, if you intubate, to achieve functional, connect to the ventilator and give the surfactant slowly as you can. Don't delay it after 2 hours. Sedation is vital, and I don't think it's a patient right. I think it's a human right to give sedation while intubation, because intubation is very dangerous and very traumatic experience for newborn babies. Thank you.
Thank you, Dr. Yahya, for clarifying this. First of all, I did not say to give surfactant in the delivery room. I said, once the baby is intubated, if he or she needs to be intubated and you have established FRC, if he requires oxygen, then it's better to give surfactant within the hour. I did not mean to say in the delivery room. So my talk is about after stabilization, after leaving the delivery room, the golden hour in the unit. The second point, I did not say we should not give sedation. I said we do not give sedation. That doesn't mean we should not give it. It happens that we are not, we don't have see the reason to give it because babies don't seem to be in distress when we do the intubation, but that doesn't mean we should not give it.
I give 3 medication.
We are in agreement. We are in agreement.
Okay. Thank you.
Bien, je vais présenter le docteur Saada Alameh, assistant professeur en pédiatrie et de neurologie pédiatrique à l'université libanaise. Elle fait partie de l'équipe du centre médical Mansour depuis 2014. Elle s'intéresse spécialement aux désordres du développement neurologique et de l'autisme, ainsi qu'au syndrome de Down. Ce jour, Dr Alameh va nous éclairer sur l'accident vasculaire cérébral néonatal ou périnatal. Merci, à vous.
Bonsoir. Good evening, everyone. Thank you for the nice introduction. Thank you for the scientific committee who were able to put this program and to do it while we are in this pandemic period. My talk today will be on the stroke in neonates, and I will be. Are you seeing my screen?
Yes, see.
Okay. So my I have just a small problem here. Okay. So my talk will be about perinatal stroke, which are a group of cerebrovascular disease that damage the brain early in life and account for most cases of hemiparetic cerebral palsy. I will try during my presentation to summarize the clinical and radiographic classification of the different subtypes and to review the current state of knowledge on perinatal stroke outcomes. So by definition, talking about perinatal stroke is an acute onset of neurological sign or symptoms attributable to focal brain infarction or hemorrhage. And by definition, it occurs anytime between the 20 weeks of gestation through the 28 days after birth. And
can you change the slide view?
You're not seeing?
Yes, we see, but you can change the slide view.
Slideshow.
من تحت اوكي on the right بعد لتحت على اليمين اكتر شوي.
wait.
Just make it show.
ايه اكيد
Okay, good.
So and it includes both ischemic and hemorrhagic events. So if this schema will present the different type of strokes, and as you can see here, they are divided into two categories: the acute perinatal stroke and the presumed perinatal stroke. The acute one are the one happening at or near birth and typically presents shortly after birth by focal seizure or encephalopathy, and it includes the neonatal arterial ischemic, the sinovenous thrombosis, and the hemorrhagic stroke, while the presumed one refers to chronic infarct and they are diagnosed in a delay manner that are presumed to have occurred in the perinatal period. And these infants typically present with early handness or seizure, leading to brain imaging and the diagnosis of a remote infarction. So if we look here, this schema presents this different syndrome according to the timing and the vascular mechanism. So the timing is very important, and it permits to understand what will happen if any vascular insult will happen. So during embryogenesis or prior to 20 weeks of gestation, early vascular insult will cause mainly brain malformation. While between 20 and 38 weeks, we have many accidents that can happen, and they are diagnosed in a delayed manner. And at birth or near birth, and in the first 4 weeks of birth, we have several entities of stroke. And we can divide it according to the vascular mechanism by having the hemorrhagic one and having the ischemic one, and then we divide it into arterial and into a venous one. So acute ischemic strokes, they are a group of stroke occurring in over 3,500 newborn. They are more, the arterial ischemic one account for almost the majority and around 80% of the perinatal stroke. Left cerebral hemisphere is affected in 80% of the neonate, and the ratio is 6 times greater in newborn than in older children. So as you can see here, ischemic stroke are much frequent in a newborn than in older children. What are the risk factors? As you can see, we have many risk factors, but none of them is inferred as really an etiology for ischemic strokes. So we have the maternal one and the fetal and the miscellaneous one. We all know that pregnancy itself, it's a prothrombotic status, and it include also acquired and inherited thrombophilia, and the preeclampsia or the infection, the labor and the delivery all lead to increased risk for maternal risk for perinatal stroke, adding on the fetal or neonatal factors. Then we go to the gender and the race. Gender, we know that boys are more affected than girls, and the black are more affected than the white Hispanic babies. So all these risk factors derived from descriptive epidemiological study, but there was no confirmed etiology in our neonatal stroke. So first case is a 40-day-old baby with hypotonia and right focal seizure. And as you can see in this image, we have a diffusion weighted image that are consistent with left superficial median cerebral artery infarct. And the network in A, we can see the network is visible at the level of the pulvinar and the splenum of corpus callosum, while in the restricted diffusion, we can see here the small cerebral peduncle lesion suggesting an early Valerian degeneration. So arterial ischemic stroke can present as seizure or encephalopathy or other asymmetry in motor function. But why seizure are predominant? Because of the special characteristic and property of the immature brain and of newborn, and the presence of high concentration of GABAergic neuron and the bilateral corticospinal control. So for investigation, MRI is very important, and you should know that in the first 2 to 5 days, we count on the diffusion weighted image because of the high concentration of brain in water. And after 5 days of life, T1 and T2 will permit to delineate the lesion and differentiate it from other non-ischemic lesion or watershed lesion. And MRI is also important to enable prognostication of the motor outcome. MRA and MRV are also important, especially when a venous thrombosis or a more other etiology is suspected. So what the other investigation, the routine thrombophilia testing is not indicated, although the screening for this risk factor as acquired and inherited thrombotic disorder in pediatric age group is recommended. There is no such recommendation that exists in perinatal period. The management consists mainly in controlling the seizure, knowing that the seizure are self-limited condition, and withdrawing of anticonvulsant treatment must be considered before the discharge of the baby. We optimize the oxygenation, we correct the dehydration. What about the anticoagulation therapies? It's rarely indicated because of the low risk of recurrent stroke after arterial ischemic stroke. So there is no indication to do it, but it must be considered in those exceptional neonates with high risk of recurrent one, including the congenital heart disease. Thrombectomy or mechanical thrombectomy also are rarely considered in neonate because there is no evidence for their use, and because of the small arteries of this in this age group, so it's not really recommended. And of course, we send them for rehabilitation or early intervention. The outcome, the majority of these babies experience residual neurological deficit. We know that there are two parts of deficit. The first one is the motor one, and this will be visible, or it could be assessed around 4 to 5 months, 6 months old, when the baby starts reaching and grasping. And this is when we find asymmetry in hand use. And the other cognitive or speech impairment, sometimes it's hard to determine before the child reach the school age group, meaning by this, not before 4 to 5 years old. And this is a necessity to follow all these baby later on in life. So we have here two studies, one showing that cerebral palsy, it's up to 68% of the children, and the cognitive up to 59%, and epilepsy up 47%. And another study from Switzerland showed that 2 years after birth, up to 39% will have cerebral palsy, and 31% had delayed mental performance. The motor outcomes were predicted by the basal ganglia involvement, while the non-cortical outcome, a non-motor outcome, were associated with cortical involvement. So the recurrence is really low, and it's higher in really in patients with cardiac disease, and this will be similar to older children with cardiac condition. The second case will be a 5-day-old term neonate who presented abruptly with lethargy and epistatinus, and when you look here, we see this thalamic hemorrhagic stroke. And if we look at the MRV, we can see this large defect, filling defect corresponding to extended thrombi, making the diagnosis of superior sagittal sinus and straight sinus thrombosis. So the clinical presentation is non-specific, the etiology is multifactorial, and the investigation again didn't show a big utility of thrombophilia evaluation. MRI and MRV should be performed to make the diagnosis. So what about the management? The American Heart Association recommend anticoagulation only in the setting of thrombus propagation. And if ever we recommend to continue it for 6 to 12 weeks. And centers who do not routinely use anticoagulation will often consider anticoagulation for thrombus propagation on serial imaging. So we need to repeat the MRV regularly to see if there is a propagation of this thrombus. And the majority of these patients will have a neurological sequela, and more serious neurological sequela are seen in those with seizure at the time of the diagnosis and in infant with large venous infarction. So if we have a seizure at time of the diagnosis, or if we have a large venous infarction, this will be associated with more long-term neurological dysfunction. Recurrence is low. investigated the recurrence risk, and in his population study, none of the 22 individuals who experienced recurrent thrombosis were less than 2 years, which means that the risk is really very low. Our third case is a term neonate with focal seizure and lethargy. And on this T2 weighted image, we have this large low signal in the right frontal cortex, and this is an hematoma. And if we look on the susceptibility weighted image, we can see this large brain area of a brain hemorrhage. Another case of neonatal hemorrhagic stroke after an existing right middle cerebral artery ischemia. We have the territory here, and we have the micro bleeding on this weighted image. And this is another idiopathic intraparenchymal hemorrhage, and I put it just to delineate, to highlight the difference in between the last MRI and this one. And this one, it's a single vascular territory, and it's spanning both anterior and middle cerebral artery territory, which will distinguish from hemorrhagic transformation of an existing arterial infarct. So idiopathic focal hemorrhage or neonatal stroke is one cause of the neonatal intracerebral hemorrhage, and usually it's more common than previously reported. It occurs in 1 in 6,300 live birth. Asymptomatic account for 15% of late preterm and term newborn. The presentation is non-specific, and the majority of them present seizure and exhibit encephalopathy, and eventually more severe presentation in case of increased intracranial pressure. Etiology, cryptogenic are more frequent, and the mechanism is consisting of primary bleeding in symptomatic case or a hemorrhagic transformation of a previous ischemic stroke. The management, correction of any low platelet, coagulation factor deficiency. We give large vitamin K deficiency in case we have a factor deficiency, and surgical evacuation of hematoma is rarely performed in neonate. The outcome, acute stage neonatal morbidity is high and can reach up to 25%, where the long term varies depending from the maturity of the brain, the underlying etiology, the location, and the extent of the lesion, and the recurrence is exceptional. What about the presumed perinatal ischemic stroke? The presumed, as we said, it did happen at some point before birth, between 24 and a term, and it's usually diagnosed with a delayed in a delayed manner. Case 5, we have a 5-month-old who was seen in ER with infantile spasm, and the parents reported diminished reaching and grasping on the right hand, and we have this lesion here. In the left sylvian territory, and the second case is a child who presented only with left hand preference at age of 7 months, and we have this periventricular white matter loss. So the majority of presumed perinatal stroke are due to periventricular ischemia. They are multifactorial, and the clinical manifestation will be or early hand preference or cerebral palsy, global impairment of cognitive and intellectual skills, and active epilepsy. The neurological examination will find a predominant upper limb impairment in typical arterial presumed perinatal ischemic stroke, while in periventricular ischemic stroke, lower limb spasticity is more predominant. And cerebral palsy is quasi-systematic as an outcome. Epilepsy and learning and behavioral difficulty are lower in PVI, and the recurrence is exceptional. So what about life after perinatal stroke? What can we say? What are the frequent asked questions? We need to know how we can determine the neurodevelopment outcome of this child based on our physical examination, based on the stroke volume, and based on our MRI. And frequently these patient will develop epilepsy. So we need to know what are the risk factors to develop epilepsy or postnatal epilepsy and remote seizure. I chose a few articles talking about the long-term outcome, and one of them is this study. The aim was oh, I don't know why I lost my screen. Okay, the aim was to look at the neurodevelopmental outcome following neonatal and presumed perinatal ischemic stroke. So they took all together arterial ischemic and periventricular ischemic stroke, and at a median age of 7 years and 6 months, there was a trend toward worse neurodevelopmental outcome with arterial. So whenever we have an arterial ischemic stroke, the outcome is more severe compared to periventricular ischemic stroke. And general cognitive ability was significantly lower in this age group as well. And of course, larger the extent of the stroke is, the poorer is the outcome. So conclusion, irrespective of the vascular time and the time of the diagnosis, all children in this study have suffered from perinatal stroke, are at risk of neurodevelopmental impairment and need long-term follow-up of motor, cognitive, and speech and language function. Another study, interesting study, and this is the first one who did look after the impact of stroke volume on motor outcome. And they took here also 37 term-born infant with arterial ischemic stroke, and they studied with diffusion weighted image that was done between 0 and 8 days, and they assessed the children neurologically at 2 years of age, and they found that relative stroke volume significantly predicted CP, and its optimal threshold for division into high and low rate of CP was 3.3%. So losing 3.3% of the brain volume with this stroke will predict CP. The basal ganglia and the basis pontis were independently associated with cerebral palsy. So early diffusion weighted image, as we said before, it's important for the diagnosis, and it's important also for the prognosis. And another study looked at the motor outcome after perinatal stroke and early prediction of unilateral. How can we predict? They looked at several modality, the general motor assessment, the hand assessment in infant, and they looked at the motor outcome between 12 and 36 months of postnatal, post-term age. Using the general motor and the hand assessment was able to predict the unilateral cerebral palsy before the age of 5 months. It's very important to examine these babies and look at the hand use in this age group, which would any asymmetry would predict the occurrence of unilateral cerebral palsy in the future. What about epilepsy? This is a study done to look after the factor associated with risk of developing postnatal epilepsy. And by definition, when we talk about epilepsy, we talk about the occurrence of at least 2 seizures or the use of anti-epileptic drugs. 78 children were included. 20% had experienced at least 1 seizure, and 18% had perinatal postnatal epilepsy. All the patients had cerebral palsy And there was a statistically significant association between the PNE and the multiple vascular territory injured. Hence, head circumference at birth below 2 standard deviation, posterior cerebral artery involvement, and the low level of maternal education. So a neonatal encephalographic abnormality were not associated with the risk of PNE. So if our baby will develop a seizure and the EEG is abnormal, it won't predict the overall the risk later on of PNE. Another study to look after also what exam should we do in infant, they looked at unilateral cerebral palsy in this age group, and they found that we have, if we combine the neonatal MRI, the hand assessment, the gestational age, and the sex accurately, identify the prognostic risk of UCP at 3 and 4 months in infant with antenatal or acute perinatal brain injury.
3 minutes, Saada, 3 minutes.
So after all, the remote seizure and epilepsy, including medically refractory epilepsy, are common after perinatal stroke, and neonatal seizures are associated with nearly 3-fold increase in remote seizure risk. Other frequently asked question, if we have the same lesion, how can we predict the stroke recovery after all? And I chose this interesting article talking about how early brain damage can cause dramatic deviation of the normal anatomy and of the sensory and the motor tract. And they propose a hypothesis that initial brain damage and the structural reorganization of the sensory motor system can form a primary source of variability among the children. And if the pattern and extent of rewiring can be identified, it may offer clinical and medical utility. So to talk about this, they did summarize how during fetal life, we have the corticospinal tract and we have the thalamocortical connection, and we have the bilateral. So each side will we have ipsilateral and contralateral corticospinal tract control, and this during development, the ipsilateral uncrossed projection gradually will weaken, and the contralateral crossed projection will become stronger, and this will explain the following image. So as we said here, we have this time graphic. Before 24 of week of gestation, we have the proliferation, and all insult here will cause malformation, while between 24 and 34, we have the white matter tract development, and the circulation will be very predominant in the paraventricular area, leading to a periventricular lesion. And then after 34, we have the cortex maturation, and the circulation will predominantly be cortical and subcortical. And postnatally, we have the cortical gray matter volume growth and tract myelination. So now if we look here, we have the lesioned hemisphere, and whenever we have attained a corticospinal tract, interestingly, these patients will do better than the other patient, or the in case of accident happening after the 34 weeks. Why? We have, because here when we have a larger lesion, the ipsilateral corticospinal tract will control the affected hand, and larger the lesion is, and the ipsilateral corticospinal tract will be more powerful. But neurophysiologically, we don't know how this this function will lead, we don't know exactly if it will be the same pattern of the the contralateral corticospinal tract.
Last minute.
Okay, so the future treatment, stem cells, many articles about this, and we know that owing their neuroregeneration property, growth factor and stem cells have a relatively large therapeutic window, but more research is needed to determine the safety and the dosage and at what time we should be using it. Many research opportunity in this field as epidemiology or risk factor diagnosis and ancillary studies, and for the treatments modalities. As conclusion, over the past decade, perinatal stroke have emerged as an important cause of brain injury. The timing of stroke can almost never be established with certainty, and much remains to be learned in this field. And thank you.
Thank you, Saada. You have 2 questions. If you can reply. We don't have time to answer now. And now we'll switch to the last session, workshop. Hadi will be moderator,
okay,
no?
Okay. Yeah. Thank you all. Thank you, Dr. Taleb, for organizing this beautiful webinar. It is on time. We are going on time. Actually, thank you for all our previous speaker. Very nice presentation. Actually, we have a very interesting workshop with Professor Itawi. Dr. Itawi, he did not send me his CV. Let me mention that I am moderating this session with my prof, Dr. Ghassan Baasiri. I especially invited him, and thank you to be with us today. So Dr. Itawi did not send me his CV, but when you go online and search for Dr. Itawi, you will find Dr. Itawi anywhere, everywhere, on Google, YouTube, Twitter, Facebook. He's very active. He is very active. Once you have to search for best video on teaching medicine, pediatrics, and neonatology, you'll find Dr. Itawi everywhere. Actually, Dr. Itawi is a consultant neonatologist at the Saudi German hospital in Ajman. He is now the director of the Arab Board Neonatal Perinatal Fellowship Program. He has many areas of interest, all aspects of neonatology, general pediatrics, behavioral disorder. He is specialized in neonatal ultrasound. He teaches us how to do it 2 years ago. And he also one of the pioneer in smart neonatal physiologic monitoring. I will not talk too much. The CV of Dr. Itawi is very long. I will leave the floor for you, Dr. Itawi. Thank you for being with us. Go ahead.
Thank you very much. I appreciate it. I feel inflated. Thank you for the invitation. Thank you for the nice word and introduction. Don't know what to say. Thank you for. I love Lebanon. And although I never visited, I was trying to visit, but I didn't have any opportunity to make it through. But hopefully in the future it will. So today I'm going to speak with you about ventilation. It is actually 12 sessions. Each one is 1 hour, and then I have to summarize it in 1 hour. So that will be a tough job. So I'm gonna pass some slide, just give you the important ones, but happy to anytime to repeat it or to answer questions. So the first slide, I will talk about monitoring. And what surprised me is sometimes people using words, and it seems it's a clinical jargons because they use the word and actually they don't know the meaning. So when you ventilate, you need to know exactly what is nasal flaring or what is grunting is, and what's the pathophysiology of it and how you treat it. What is retraction? What is tachycardia, cyanosis? What is the cyanosis in relation to such, desaturation? The important also monitoring is ultrasound as an emerging tool, and also X-ray and how to read them. Of course, invasive blood gas and non-invasive blood gas monitoring. And also in ventilate babies, you know how to use graphics and loops. Actually, the ventilation since 2010 have been revolutionized with graphics and loops, and we can ventilate in a state of art using these two parameters. Now, when you read an X-ray, whether your baby ventilated or not, you need to develop a system. So some say, well, I will start from inside to outside. Others will say, no, I'm from inside to outside, or I will go by systems such as muscle, bone, and so on. But you always need to comment on the symmetry and the clavicle status, the ETT, and so on. I don't want to go in details how to read an X-ray. The new things that will help us to ventilate and also diagnose almost all the diseases, non-invasive or quick, are the lung ultrasound, where you need to know the A lines and B lines, the air bronchogram. You can see the sliding, the goose sign of intubation, the diaphragmatic excursion as a sign of correct placement of the tube and preventing of selective intubation of one side. You can see the sky ocean sign or barcode sign of pneumothorax, the mirror image, the subpleural consolidation, and you can assess many diseases in ultrasound, RDS, TTN, pneumonia, and so on. The list goes on. You need to monitor the blood gas, arterial, venous, and capillary. I will speak about them in few coming slides in details. And of course, you need to know the non-invasive monitoring. The importance of non-invasive, they are continuous, and they reduce blood supply. They reduce also the need for transfusion. They're non-costly, but always blood gas is necessary for calibration, and if you want to look to the acid-base status, and when you have hyperoxia. So the first one is the pulse oximetry. And again, I don't want to go to details of pulse oximetry, but it has advantages and disadvantages, and one should know how to use it. What is the advantage? What's the disadvantage? And what surprised me that many people don't know the sampling time of the pulse oximetry. And they always look to the real-time oximetry, but we need to look at oximetry in a smart monitoring way. So we can generate histogram, we can generate tachogram, point care, and also frequency table, and it can tell us the trend and the dynamic of the saturation, and it can help us lots of monitoring baby smartly. Again, it has advantage and disadvantage, so I'm gonna pass it. Also, we can measure the transcutaneous oxygen. And the difference, the pulse oximetry measure the percentages. So it has a lot of margin of error when you go to the extreme, more than 95, less than 60. However, in transcutaneous oxygen, you're measuring number, and therefore you can measure the hyperoxia, and you can measure numbers more than 100. And it is a electrochemical sensor, and therefore it uses oxygen permeable membrane, and therefore it causes irritation of the skin, and therefore you need to replace it frequently. Now that's not the case with pulse oximetry, and also can cause skin injury. And it depends on the perfusion, therefore poor skin perfusion affect the measure. The advantage is non-invasive, and the other advantage over pulse oximetry, it can measure the hyperoxia. Transcutaneous CO2, it is the same principle of transcutaneous oxygen, and it have the same advantages and disadvantages, including recalibration, and the recalibration usually every 4 to 6 hours, and relocating the transducer to prevent skin injury. We have another one, which we call it end-tidal CO2, and in this we measure the. Actually, we have now better than end-tidal. We have the capnography, where it can measure the CO2 during in and expiration. However, during inspiration is not that important. Expiration is the important, and therefore the end-tidal CO2 give us a lot of information when we ventilate babies. It has actually, advantages and disadvantages. The most important of the limitation is when the heart rate goes up or the respiratory rate goes up, the accuracy decreases, and also it gives us a dead space. So you can use the mainstream in tidal CO2 or side stream in tidal CO2. Both of them have advantage and disadvantage. You can also use a separate tube to measure CO2. However, when you use double lumen separate tube, you increase your tube diameter, and therefore in small babies you cannot use it. One of the most important actually is monitoring of ventilation is your FiO2. And please and kindly remember, if you need FiO2 more than 40% for more than 1 hour, there is something wrong, either in you or in the machine or in the baby. So you need always to assess, never leave baby more. It's easy to turn on the knob temporarily, but it's wrong to keep the knob turn on continuously. So inspired oxygen monitoring are vital. The other monitoring is pressure. We're monitoring the pressure. It's a PIP, it's a PEEP, and it's a mean airway pressure. And when we look at the ventilator at the graph and we look to the pressure wave, we can find 3 types of wave: the mandatory wave, the that delivered by the machine, and the spontaneous wave that delivered by the patient, and the assistant ones that started by the patient and keep on by the machine. So one of the important airway pressure is the PIP, which is the maximum pressure during inspiration. And you can see that you have mandatory breath, you have the spontaneous breath, you have the synchronized breath, you have the unsynchronized breath. Graphics are vitals when you're monitoring the ventilation. Also, we can monitor the ventilation by loops, and the loops give us the dynamic of one breath, while the graphics give us the trend. In the graphics, you have pressure, flow, and volume, while in the loops, you measure 2 readings. So you can see the most important loops is the volume versus pressure, and it tells us lots of information: the safety zone, the dangerous zones, the increased resistance, the decreased compliance, increased compliance, the hysteresis, the opening pressure, the closing pressure. It tells us lots of information, whether the baby is happy or the baby is not happy, the sedation is appropriate, the sedation is not appropriate. The change in dynamics all can tell us from looking at one loop. We can measure compliance and resistance. Now, these 2 readings that I don't like in neonatology, and the reason, because compliance and resistance are based on assumptions. The first assumption, 0 leak. And you know we don't use cuff tube, so always you have leak. So once you have leak, compliance and resistance, not of no value, but you need to consider that. The second assumption, that the compliance is the measure and resistance is the measurements of airway and lung compliance and resistance. However, the actual readings in babies reflect the transthoracic compliance and resistance, because our rib cage are not strong enough, but it is pliable, so it contributes to the compliance and resistance. So when you have high or low compliance and resistance, that does not mean the lung, it might be the transthoracic compliance and resistance. There's another things that we can monitor is the time constant, which is the result of multiplying compliance versus resistance, and the optimal time constant is 3 times the time constant, and it gives us the inspiratory time, and it ranges between 1.3 to 0.5. The other measurement that we measure and monitor is respiratory rate, tidal volume, and minute ventilation. Minute ventilation is way better than tidal volume because it gives you holistic performance during ventilation over 1 minute, where the tidal volume. Now, there are beliefs, and I don't know from where that belief comes, that the PEEP caused pneumothorax. And that's what I call it peepophobia. So that's what I'm trying to fight always, that pneumothorax is a disease of change. So if you have change of sound, change of waves, change of volume, change of space, So anything changes is a risk of pneumothorax, but if a constant is not a risk of pneumothorax. So for example, if you have non-homogeneous lung disease, that's a risk of pneumothorax. If you have lots of like DJ or country music, sudden music, that's a risk of pneumothorax. Any change with time is a risk of pneumothorax, such as tidal volume, such as respiratory rate, such as inspiratory time. All are risk of pneumothorax, but not the PEEP. So there is always, we use low PEEP, and I'm going to explain later on what we call a dynamic PEEP or the best PEEP. So these values are very important to monitor during ventilation. From the monitoring of the ventilation and respiration, I'm going to go say a few words about oxygen delivery system. So the oxygen delivery system, either from a central source or cylinder, and each one has advantages and disadvantages. So I'm going to pause this because I want to deliver more information. Now, what I don't like in textbook saying provide oxygen, and that's totally, I think, wrong. We should always say blended oxygen, or we can replace it by provide respiratory support. I don't think it is correct to use oxygen or pure oxygen. Our body, our human body tolerate 21% room air because we cannot detoxify oxygen radicals. So giving pure oxygen is wrong. Oxygen always has to be blended. And when you blend the oxygen with the flow using a medical air, not air, but a medical air, and then you can see that the set flow and the set FiO2 deliver a different measured oxygen. So if you put FiO2 of 40% and a flow of 1 liter, the result is only 27 and so on. So the more FiO2, the more the delivery, the more the flow, the more the delivery of the oxygen. So one of the important points, remember, is a blended oxygen, not a pure oxygen. The blended oxygen use 2 gauge, the black one, which is the medical air, and the white one, which is the oxygen, and then blended again. And therefore, you have 2 control knobs. You can control the gauge of the flow and the gauge of oxygen. There are many ways to provide blended oxygen, and also don't have time to go through it, but we can do blow-by. Each one has the percentage that oxygen, an indication, and the precautions. We can provide by nasal cannula from 1 to 4 liter. We can use simple mask. And I was very surprised when I asked a board student, what is Wilson McKitty or what is Shidyaki Gashi? They answer it right away. But when you ask them what is simple mask, they don't know what is exactly simple mask. And also you need to know the partial rebreather mask and the non-rebreather mask and the Venturi mask. Also the hood, the tent, the self-inflated bag, and the flow-inflated bag. Each one can provide a certain percentage of oxygen, blended oxygen, and it has certain indication and some precaution. So the blow-by is providing oxygen without contact with the patient. And again, I don't have time to go to details of blow-by, but it's very important to be used in agitated patient during resuscitation, during preparation of non-invasive or invasive ventilation. And it can only provide oxygen less than 30%. If you need more than, then the blow-by is not your mode. There is also the low flow. I don't know why this is moving very fast. Okay, so another source of blow-by is the nasal oxygen. It can use nasal mask or it can use nasal prong. And it's of 4 types: the microflow, the low flow, the normal flow, and the high flow. Each one has advantages and disadvantages. So the microflow is, we use from 0.01 to 0.5 liter per minute, and it always use 100% oxygen, and it is only for chronic use of oxygen and home oxygenation. The best, if you want to use it at home, use the multi-flow Venturi system through a mask or through nasal prong to provide it. The high flow It is any flow more than 4 liters per minute. However, some say it's more than 2, but I would say more than 5 liters per minute. And when you use a high flow, remember that the pressure is the speed of the flow. And therefore, when you provide the flow, remember that is a CPAP, so you're giving a pressure. So when you provide the flow, you're providing CPAP, but it's unmeasured. So remember that. And because it's unmeasured, it has a complication. And therefore, it is not advisable to use high flow in babies less than 35 weeks, or some people say 32 weeks. The reason, because the pressure in the flow is unregulated, and thus cause dryness of the upper airway, cause irritability, cause complications, and it also can increase work of breathing. Because delivering CPAP is a flow, and the CPAP mostly you need flow somewhere between 6 to 15. So if you need a flow less than 15, CPAP is more indicated. Now the high flow can be delivered in different way. It can be delivered by mask. It can be delivered by nasal prong. I also want to speak about mask. The mask has advantages and disadvantages. The main advantages is losing the access to the mouth. If the baby aspirated and vomited, it might aspirate. So it is really a good temporary oxygen delivery device, but it's not great. So we have the simple mask. I don't want to go into details of the simple mask, but basically you have opening so the baby exhalation outside and the oxygen source come from here. If you have multiple gauge or gate of the flow, it becomes Venturi, and you can see each one have a different color, provide different flow, and then you can control the flow. You have the partial rebreathing. So in this situation, you have a valve that allow you to breathe out either from one side partially or from two sides partially, and therefore the baby can rebreathe the CO2. Or you have the non-rebreathing, where all the air goes out, and when the baby breathes in, and it's a one-way valve, when the baby breathes in, it comes from the reservoir that is connected to the oxygen. You have the enclosure system, which is two types, the hood and the hood and the tent. They're very old. They're not in common use. There are lots of disadvantages, loss of oxygen concentration, having a mist, decreased access to patient, but each one, the tent and the hood, have advantage and disadvantage. We can also provide oxygen by bags. We have flow inflated bag and self-inflated bag. It's well known because it's a common description in NRP. Each one have a side effect and advantages. From the oxygen delivery system, I want to move to non-invasive ventilation. And non-invasive ventilation is the delivery of mechanical support without using ETT. You can use nasal prong, you can use mask, you can use face mask, you can use helmet. And they're basically of two types. The continuous positive pressure, which is the CPAP, and the bilevel airway support. The non-invasive, it has the ability to decrease work of breathing and do some gas exchange. It is very good in avoiding intubation, and it avoids sedation, avoid neuromuscular blockade, and it can easily be used for transport in the emergency department, in PICU, or it's a step down in intermediate care. Now remember that non-invasive ventilation causes full gas exchange, so provide oxygenation and CO2, while the high flow oxygen delivery, it's a heated humidified oxygen. It delivers oxygen, but it does not with CO2, so it's not indicated in hypercarbia. Both they need interface, and the interface can be nasal cannula, nasal mask, full face mask, helmet. And these should have a characteristics or the selection of one of these depend on the comfort, on the fitness, and what is the least side effect, especially the skin breakdown. To use the interface, we can use the hydrocolloid dressing gel to avoid skin damage. We can use air or gel cushion to distribute the pressure, the applying pressure to distribute smoothly and prevent skin breakdown. Now, very important point in preventing skin breakdown is appropriate size and proper fitness and cycling between mask and prong. Fixation, you have many ways. You have the 4-entry fixation, and sometimes you have 5-entry fixation. The type first, we said CPAP. When CPAP provide any pressure, and people always mix between CPAP and PEEP. And please remember, CPAP is not PEEP. They're totally different technology. They're totally different benefit. They are two different things. Don't mix that. CPAP is not PEEP. So you cannot say CPAP PEEP of 6. It's CPAP 5 centimeter water or 6 centimeter water. The other type is non-invasive positive pressure ventilation, and or the other way is called BiPAP. So if it is not is provided from the ventilator, it's called BiPAP or BPAP, and basically has two set values. They have the IPAP and the EPAP, and they call it BiPAP or PiPAP when it's delivered by the ventilator. Now, the indication of non-invasive ventilation are many, as you can see here. And the contraindication, basically, if you need the ETG. Or if the baby is or the child is unstable. So now there is a few points that I want to say. There is something called continuous flow CPAP, or not continuous, constant. This is a wrong, constant flow CPAP. The constant flow CPAP are of two types, the bubble CPAP. And the bubble CPAP is basically, you have a blended oxygen connected to a humidifier, and you have the other side that goes to the patient airway, and the other side are immersed in a column of water, and it's labeled in reverse way, and the depth of the tube determine the level of CO2. So if you put it 4 centimeter, you're providing 4 centimeter of CPAP. The bubble CPAP needs humidifier. Now the problem with this, lots of leak, and lots of it's a cheap, it's easy to assemble, but lose lots of manpower. So you need nurses. So it is cheap, but it is very hard on the nurses. The other one is of the constant flow CPAP, this is wrong typing, is the ventilator-driven CPAP. Now this is only should be used for temporary CPAP, because the ventilator CPAP depends on Venturi principle. It generates the CPAP by at the exhalation valve. So the baby will breathe the whole way from the nose through the circuit to the ventilator, and that would increase the work of breathing. So it can be used with transport, it can be used as step down, or it can be used right away after extubation, but should not be used for a long time. Now, I think one of the revolution in ventilatory support is the discovery of variable flow CPAP. And the variable flow CPAP can provide CPAP or CPAP. The CPAP is when the machine allows the baby to sigh, or you can provide also advanced CPAP. So it can provide, and here it does not call PiPAP or EPAP because this is not a ventilator driven. It decreases the work of breathing because it decreases the expiratory resistance. And the way it does that, it is because of specially designed prong. So, so you can see that when the baby breathes out, the machine breathes out. When the baby breathes in, the machine breathes in. So the baby, and this is what we call it fluidic flip principle, and this achieved by the curvity of the one of the side of the prong. And this allowed to decrease work of breathing because the baby breathes out in like less than 1 centimeter, not like the ventilator-driven CPAP. And you can see here is the nose generator where the baby, when he exhales, it goes from here, but when they breathe in, it comes from here. And this is the jet controlled. So what is the mode to deliver CPAP? We can deliver by the mask. We can deliver it by nasal prong. We can cycle between mask and nasal prong. We can use nasopharyngeal CPAP. This is very important in transport. I used to use it. And some people use ET CPAP. ATT CPAP, I do not advise it because we have now the pressure support ventilation, which is way better than plain CPAP during intubation. They use it as a trial of CPAP before intubation, but because of the presence of PSV mode, I think this been outdated. So I'm gonna move this, the pipe up, we've explained it's a 2-level CPAP. The way you set the CPAP in the constant flow CPAP, you can start from 5 to 15. And I use what we call a dynamic CPAP. So I give order to the nurses. It depends on the situation. You know, you have CPAP from 5 to 8, for example. I sometimes start 8 and tell the nurses to go down, or I start 5 and tell nurses to go, depend on the situation and the gestational age and postnatal age. And if it's bi-level CPAP, I set the EPAP and the IPAP, and the EPAP usually 5. The problem with this is the delta wave, because if the delta wave become small, it fails, and therefore the plain CPAP, the eCPAP will be low, and that might cause some collapses. So you need to be careful when using it. What is the sedation that I use with non-invasive ventilation? The best I use is dexmedetomidine. And this is alpha-2 agonist, and it's the same family of clonidine and guanfacine. And it's really good one because it can be used as a sole or as an adjunct and has less respiratory depressant. However, sometimes you are obliged to use midazolam or chloral hydrate if it's oral. How you assess the effectiveness of non-invasive? I'm going to pass this because of sake of time. Predictive failure, benefit, I'm going to pass it. Complication, I'm going to pass it. And this is the about CO2, blood gas. I'm also going to pass the blood gas. The only way that I want to read is the gas slip. So it's very important when you read blood gas to go through a process. Please do not treat a blood gas. First, check if you have a previous blood gas. Second, why you ask for the blood gas. And third, how the blood gas was collected. What is the transferring method of the gas? Is it arterial, venous, or capillary? And please do not use venous gas in neonatology. The only indication of venous gas is when you want to measure the oxygen consumption rate, which is the difference between arterial PO2 and venous PO2. And then after you answer all these questions, you need to answer whether the baby is on ventilatory support or not, and then treat the patient. So you will see that the slip, you will see a temperature, and when you read the slip, and it's very important to look at this temperature and look at the temperature of the baby. If there is discrepancy, then your gas is wrong. You need to do correction, especially if you're doing hypothermia. So you should see measured values, okay? And you will see the abnormal hemoglobin oximetry. And remember that the only measured value in blood gas is pH and PCO2, the rest are calculated. Also, you will use the oxygen parameters. And you will use, if the machine is good and it's a high quality, you will use the correction. If the temperature of the baby look like the temperature of the machine, then you ignore this section. And you can have other measurements such as sodium, electrolyte. And also you will see the entered value, the values that entered by the respiratory therapist or the nurse. So I'm gonna pass all this. I don't think I have time to go through this. So I'm going to pass the interpretation of blood gas and start right away the principle of ventilation. Now, the most important when we talk about the principle of ventilation is the PEEP and PIP. So the PEEP is the pressure that maintain the lung inflated during expiration, okay? And it's measured above 0. And when the machine tells you 0, it actually means the atmospheric pressure. And most of the ventilator-driven machine consider the atmosphere is 0. So the PEEP is the pressure applied to the upper airway to keep the airway open during expiration, while the PIP is the pressure during inspiration. The physiological of PEEP is 3 to 4. So please don't use 4 because this is physiological. You always, when you need support by the machine, you need to go more than 4, more than physiological. The other one is, what is the best PEEP? The best PEEP that we use. Now, the best PEEP is to achieve the functional residual capacity. So you can see that at some point when you increase PEEP, you get better alveolar diameter. And when you get better alveolar diameter, you start to match the vascular bed. So more distension, more meeting of vascular bed, more meeting of vascular bed. You reach a point between 10 and 15 that there is more stretching, but there is no improvement in the alveolar diameter. And therefore, there is no improvement between the contact of alveolar bed and the vascular bed. And that's what we call it the best PEEP. The best PEEP is the PEEP that when you increase, you get better alveolar volume, not getting any alveolar volume after increasing PEEP. That is a not good PEEP. So this is where you get PEEP. And good PEEP where the vascular bed meet the vascular bed. If you get more, you get hyperventilation. If you get less, you get what we call it intrapulmonary shunt. And again, I need to stress on a point that CPAP is not PEEP. CPAP is the pressure applied to the nose above atmospheric pressure. PEEP is the pressure need to keep upper airway open. Now, when you look at the graph, you need to remember that from the Pmax to the plateau represent the airway resistance, and from the plateau back to the PEEP represent alveolar compliance. This is very important to remember. What is the advantage of PEEP? It improves the functional residual capacity. It causes better contact between alveolar bed and vascular bed, decrease shunt and improve oxygenation. It also increase compliance, decrease work of breathing. Now the type of PEEP, we have applied PEEP that we put on the baby. We have the auto PEEP that generated by the baby. So when you have short inspiratory time or you have early breathing, the PIP will not return to the starting point. So it will be having some point that does not reach to, and that's what we call it auto PEEP. And this is very important in chronic lung disease and also in asthma to make sure that you don't have auto PEEP and you need to adjust it. You can see the auto PEEP in here, where you can see the expiration does not reach to the 0 before the second inspiration starts. The PIP is the pressure during inspiration, and it's of 3 types: spontaneous, mandatory, and assisted. The rate, you all know, I'm going to pass this. The inspiratory time is very important, and it's triple the constant time. The inspiratory time or the length of the breath are 2 types: the time cycle and the flow cycle. The time cycle use of most of the modes, while flow cycle are used in the PSV. So it depends on the flow generated by the patient to determine the next cycle. There is also another parameter is the IE ratio, where it's the number of inspiration versus the number of expirations. It can be 1 to 1, it can be 1 to 3, and sometimes we use reverse. So the longer we use it when you have air trapping or you have increased airway resistance. We can use inverse ratio, and it's rarely used in neonatology, where you have long inspiration and short expiration. We have the mean airway pressure, or called PAU instead of MAP, because to avoid the confusion with mean arterial pressure. And it is somewhere between 10 to 15 centimeter. And the mean airway pressure is a risk of pneumothorax and PIE. Now the MAP of high frequency is different from the MAP of the conventional ventilation. We have the minute ventilation, we've talked about it. We have the tidal volume. And depend on the tidal volume and the size of breath, we have two modes of ventilation. We have the volume limited and pressure limited, and we have the adjunct contribution to the pressure limited, which is the volume guarantee. Again, in tidal volume, you'll see 3 breaths. It is important when you ventilate, you look to the dynamics, especially the pressure volume loop, because it gives you the compliance. So you can see from the start where the PEEP, the pressure will increase, but there is no volume until it reaches a point where there is sudden increase in the volume. That's what we call it opening pressure. If from the start of PIP to the open pressure, double the PEEP, then you're doing something wrong. You need to correct because you are under recruiting. And then you reach to a point where you increase the pressure, but you don't get volume. So that's what we call it, the overinflation. And then the baby starts to breathe out, and it reaches the point that you decrease the pressure, and there is no change in volume. At some point, there is sudden drop, and then we need to avoid this area, and we need to avoid this area. This is hyperinflation, this is underinflation, that's what we call it. Also, if you draw a line here, you get the compliance. And from here, from the midline to the end here, and from the midline to end, we call it hysteresis. And it tells you the obstructive and restrictive lung disease. So you can see also other type of loop is the flow volume loop. And you can see the inspiration and expiration. And I just don't have time to go through because of time, and I need to move fast. Another type of the flow volume loop where there is obstruction, other way when there is a restriction, and also a part of the monitoring of ventilation is the graphics where it tells you the trend. So we have different type of pressure. So you can see the volume limited, the pressure limited, the volume limited, and the sinusoidal of the volume targeted pressure limited. We can also the waves of the flow, and there are very various waves. We have decrescendo, we have the square, exponential, different type of wave, each has a meaning. We have also the volume waves, and we have different type of waves. We have the graphics of the volume and pressure. And also we have the graphics can show us the phase of respiration, the triggering, the maintenance, and the cycling. The type of breath, we have the mandatory, we have the assisted, and we have the spontaneous. And we have the trigger can be volume, pressure, or neural. And simply the trigger, the machine measure the in and the out. If the in not equal out, then there is ventilatory effort, there is a baby effort. So in, out. If the baby is breathing, breathe with it, they will not be equal. If the baby is not breathing, then they will be equal. So if they're equal, no trigger, and there is a trigger. So what is that is very important in ventilation is the ventilator variables. We have the control variables, which is independent variables. And they are the pressure, the volume, and the flow. And they are expressed as a function of time. So remember that the flow over time is the volume, and the speed of the flow is the pressure. We have also conditional variables, and they are dependent variables because they are dependent on the independent to achieve the patient support. And we have also the phase variable. It determines the start, such as the trigger, the sustain, such as the volume or pressure control, and the end, so which is the cycling. From all these variables, we can have the mode of ventilation. We have the volume limited ventilation. In this ventilation, the clinician set all the values but the volume. But the pressure. So set the PEEP, the tidal volume, and so on, but not the PIP. And in this, in volume or pressure limited also, the mode of ventilation is determined by the amount of the machine performance and the patient performance. If there is no patient or machine ventilation, then it's a CPAP. When it's mostly patient, it's a PSV. When more machine, less patient, it's an IMV. When it's equal 50-50, it's SIMV. When it's more machine control, it's assisted control, or airway pressure release ventilation more, and control mandatory ventilation is mostly machine delivered. The mode of ventilation, we have the controlled mechanical ventilation and we have the assisted control. The controlled mechanical ventilation is we provide everything. Patient provide nothing. Assisted control, we provide everything with a limit. Over that, the assisted provided by the patient and assisted by the machine. We have the IMV, which is some sort of assisted control but not synchronized. And we have the PSV. It is assisted control, but it's a flow cycle. It's controlled by the patient. And you have the tube compensation. Remember the tube compensation because the baby is breathing for that. So the less you need, the less you need to provide, the wider the tube is. So what is controlled mechanical ventilation? Controlled mechanical ventilation is you control everything. The rate, the PIP, the PEEP, the baby is either not breathing or paralyzed. And this is the controlled mechanical ventilation on the graphs. So you can see controlled ventilation, no spontaneous, no assistance. Because if there is assistance, there will be trigger. No trigger, you can see here. While in assisted control, so it's the same control, but to the backup rate. So you provide control to like up to rate of 40 if you said rate. Any baby breathe more than rate, it will provide as assistant. So this is assisted control ventilation by graph. So you can see this is controlled, but when the patient triggered, it provide help. So you can see same of mandatory, but with extra assisted. Intermittent mandatory ventilation is the same of assisted control, but unfortunately is asynchronized. So you can see the controlled, spontaneous, not supported, spontaneous, not supported. Another spontaneous came again as the controlled one. So this is a problem when the patient starts to fight the ventilator. While the SIMV is the same of control of the IMV, but it's synchronized. So you can see that the spontaneous will not be supported, but when the baby should breathe in, you can see the trigger, the machine will support, but will never work against. So the comparison between SIMV and assisted control provide the backup rate, all control, and when the patient breathes over that, it will be also supported. SIMV provide only the backup rate, but when the baby breathes above, it will not be supported. Now, the most important for me is the pressure limited ventilation. The pressure limited ventilation is you set the PIP to prevent paratrauma, but the baby will achieve the tidal volume they want. So The volume control ventilation or volume guarantee ventilation is used with the pressure limited. So we set the PIP and because the volume will be variable, we set the in addition to the PIP, we set the volume guarantee. So yes, give the PIP necessary to achieve tidal volume, but to a limit of the volume guarantee. The airway pressure release ventilation is not used in neonatology, but it's actually a reverse of ventilation where the PEEP represent the PIP and the PIP represent the PEEP. The PSV, the most important for me is the PSV. The PSV is assisted control, but it's not time cycle, it's a flow cycle. So you can see here that the patient trigger, the flow goes up, reach maximum. From here to here is 100%. And then you tell the machine that when the patient achieves the crescendo of, let's say, 40%, start another cycle. Stop the ventilation, stop the inspiration. So you can see the patient here, stop. The flow did not go to zero. This, the more you make it up, the more difficult for the patient. So if you put it 40%, the patient will achieve the crescendo of 60%. If you put it 20%, the patient will achieve the crescendo of 80%. So if the patient, and therefore, if the patient achieves 80% flow, then the machine will stop the ventilation, and therefore the baby will drive the ventilator. However, this is very important to remember. You cannot use it for a long time, and you cannot use it for a weak premature baby, because using it in a weak premature baby, like using the PSV or telling a drunk driver to drive a car, after a while they will make an accident. After a while the patient will be exhausted. You can use also combined mode, so assisted control with VG, or SIMV with VG, or PSV with VG, or even assisted control VG plus PSV, where you provide all the control as a controllment in ventilation, and the assisted as PSV. So you can do lots of combination. Now, I cannot stress more on the graphics. I'm losing the time, right?
7 minutes remaining.
Oh no, I have lots of more to say. Almost didn't reach the 50% of my presentation. So the graphics can tell us the trigger, can tell us the limit, and can tell us the cycling. The trigger can be machine control and can be patient. Well, that's what we call it, control and assisted. The limit can be pressure and can be volume, and the cycle can be time and can be flow. So already talked about type of breath. There is very important point is the rising time, or the ramp. And it's very important not to make it sharp, not to make it slow, because if you make it slow, you will not achieve the tidal volume. If you make it sharp, you cause upper airway dryness. So always you like to make it, moderate. So I'm gonna pass. Time constant we've talked. Cycling, if you remember the flow cycling, so you have the crescendo, you reach 100% and then drop. So if you tell the patient that, or the machine, 30% of the time, so that's mean when the patient achieves 70%, the breathing will stop. If the patient achieves the 40%, the 70% by 0.5 second, or by 0.2 second, or by 1 second, the machine will help. However, you have to put a limit in a time, and therefore in PSV, you have always to put the cycling or the time, inspiratory time, a little bit longer for the patient to control the cycling by flow. Pressure. How to increase MAB? You can increase the rising time you can increase the plateau, you can increase the inspiratory time, you can increase the PEEP, or you can shorten the rate. So all this can change the map. The most important when you look at waves, look at inspiration and expiration. You have to press on this point, is that this should be equal this. If they are not equal, then there's something wrong. This size should be like this size. The elevation should be like elevation, almost should be same. If they are not equal, then you have a problem. So you can have when this goes up and goes down, and then from 0 goes back, then you don't have leak, you don't have air trapping. This area of start should not be long. This one should not be long, should not be short. If it's long, that means the baby has no time to breathe out once finished breathing. When it's long, the baby breathes in and then has to wait the ventilator to breathe out. So this one should be very reasonable time. When you look at the volume wave, you have to look at the inspiration and expiration, and there should be almost equal in size. Pressure volume loop, we've talked about it. It tells you lots of information, tells you the resistance, it tells you the compliance, it tells you the opening pressure, closing pressure, under recruitment, over recruitment. The flow volume loop is very important, tell you about the functional residual capacity and peak inspiratory and peak expiratory. Also the loops and graphics tells you the relation between the patient and the ventilator. You can see here short inspiratory time or leak or PSV mode. When you see this, you have 3 possibilities. Leak, when you see that this one is not going to 0 before the next start. So you can see this one should be 0. If it's not 0, then you have a problem. Either leak or short inspiratory time, or you have PSV mode. Now the new ventilator, it gives you the patient contribution in a color and the ventilator contribution in another color. And you can see the leak easy. You can see the leak here because it's not coming back to 0. You can see the trigger and also it's not coming back to 0. So you can see the leak, very important. You can see the leak here in the tidal volume. You can see the leak also in the loops, whether it's a pressure volume loop. So you can see it's not start from 0. So whenever you are not starting from 0, and you can see the leak is not going back to 0. So it comes here. You can see the leak here. You can see the leak here. So the leak can be seen in many areas in the ventilator. You can also see this one is not going back to 0. So you have inspiration, expiration is not. So air trapping. So you can see the air trapping easy. Air trapping. I don't know if I have to stop here. You can see air trapping. So if it's inspiration, it is leak. If it's in the expiration, it's air trapping.
Yeah. Dr. Aitawi, I think let us open the discussion for the panelists. I think we'll have 5 minutes to get some question. I have 2 questions actually, and I invite everybody in the panelists and of attendees to send question. My 2 questions. Thank you very much for the very helpful and informative presentation. My 2 questions and practical questions. The first one is any idea about non-invasive monitoring, like not doing ABGs, only SpO2, the first one. The second one.
Okay, go ahead.
The next one is what I would like to ask. Okay. In which type of or on which mode of ventilation you don't like or you have to sedate the baby? You mentioned very multiple mode of ventilation. In which mode we don't have to sedate the baby, or you have to sedate the baby? Thank you.
Okay. So the first question, the non-invasive monitoring is far way beyond only the CO2 and the oxygen monitoring by non-invasive, by pulse oximetry or transcutaneous oxygenation or transcutaneous CO2 or intidal CO2. Part of the non-invasive is the smart monitoring. So convert all these to histograms and tachogram and point care. So it needs a presentation how to do that. I need another talk. The other point is that there are other tools for non-invasive, the lung ultrasound and the NIRS. Do you need gas? Yes, definitely you need gas, because you need gas to calibrate. You need gas to assess the acid-base status, and you need gas also when you have hyperoxia, because hyperoxia cannot be measured by the non-invasive. Now, you should sedate babies? No, you should not sedate babies unless the baby tells you to sedate. So if you have patient ventilator fight, you have to sedate, okay? And you have to use the least sedation that possible. And you can use the non-pharmacological and pharmacological. So, but for intubation, you have. Now, the evidence is very strong, and it's very painful procedure. It's very traumatic. And I never intubate baby unless emergency. Now, the problem with the definition of emergency, what is emergency? Because for me, if you can provide positive pressure ventilation, then this is not emergency. The emergency only if you cannot provide PPV, that you should intubate without delay, such as you have shock and you cannot provide PPV, or you need to do chest compression and you need to do it quickly. That's an emergency. Otherwise, intubation in labor room is not emergency. Intubation in an ICU is not emergency. As far as you can provide PPV and wait until the medications comes. So sedation is a must for intubation, but it's not a must for ventilation. But it is must in certain situations, such as when you have pulmonary hypertension, such as when you have surgery, such as when you have to use very high setting to control the parameters. And when you provide sedation, you can drop down your setting.
Okay. Any comment, Dr. Lama, Dr. Maalouf, Dr. Monika, Dr. Basiri?
So let's.
Thank you. That was very helpful. Thank you very much.
Unfortunately, the time is short, but otherwise,
yeah, I think it doesn't give it its value, because it deserves a whole webinar by itself to be able to delve into the details of ventilation. It's fascinating, actually, but it deserves its own time.
Yeah. Dr. Rami, do you have comment?
At all, I think it was a very interesting topic, even it's not enough. Thank you.
Thank you very much.
Welcome. Thank you very much, Dr. Aitawi. Akid, we hope that we will have you next time in Lebanese webinar.
Thank you very much. Thank you for the invite.
See you soon.
Thank you very much. Bye-bye. Assalamu alaikum.
Bye-bye. Alaikum assalam. Bye. Bye.
So now we'll move to the last session by Dr. Pierre Haj. Dr. Pierre Haj is a pulmonologist and allergologist, associated professor of clinical pediatric University of Parliament, and he will talk about cow's milk allergy protein. So Dr. Pierre, please, we are waiting for you.
Good evening. Are you able to see my presentation?
Yes, yes.
Clear.
Okay, so I will begin. So since I'm the last speaker, I want to thank everybody for assisting to this long day and webinar. I want to thank Novalak for organizing this and for sponsoring my conference, because I will be talking only about cow's milk allergy. It will be a reminder for all the pediatricians in assisting to this webinar. Before going into details, I want to remind you about a few things, that every time we are adding new food to any kid, we might face reactions. Those reactions usually are divided into either immune-mediated reactions or non-immune-mediated reactions. The non-immune mediated reactions are very common, secondary to additives, to sulfites that are mixed with children's food and to our food. Sometimes they can be either like lactose intolerant, they are metabolic, sometimes for added toxin in the food, for added pharmacological product in the food. The child might have a reaction to this food, and this is not called allergy. The allergy is an immune-mediated reaction. It either can be IgE-mediated, non-IgE-mediated, cell-mediated, or a mixture between IgE and non-IgE-mediated. So for this classification, we'll be focusing in the next 15 minutes only about food allergy from IgE to non-IgE. If you look at the IgE-mediated allergies, usually it reaches around 10% of kids. It's mainly a kid problem more than adults. The common allergen are milk, egg, wheat, soy, peanuts, and tree nuts, shellfish, and fish. The diagnosis of IgE-mediated food allergy is very easy, and the treatment is eviction. While for the mixed type IgE and the cell-mediated food allergy, you can face atopic dermatitis in children and in adults, and it reaches sometimes up to 37% of atopic kids. And the allergen will be also milk, egg, wheat, soy, peanut, tree nuts, shellfish, and fish. And sometimes you can order all the investigation and you might miss some of them, and you might miss your diagnosis. While for the GI doctors, they might face eosinophilic esophagitis that can be either in children and even in adults, more in males than females. And the allergen most incriminated in the eosinophilic esophagitis are milk, wheat, egg, beef, soy, and chicken. The kid will be vomiting, having severe failure, dysphagia, food impaction, and heartburn. While there are other eosinophilic gastrointestinal disorders, even in adults, in kids, and all of them can be secondary to milk, possibly milk in adults, and other food. Non-IgE-mediated food allergy are the food protein-induced enterocolitis, enteropathies, and all of them can be seen either in infants, in toddler, and in children. And nowadays, they are talking more about this problem even in adults. The kids will have intermittent vomiting, severe abdominal pain, failure to thrive, some rectal bleeding, some malabsorption problems, some really blood-tinted stools all the time, some difficulty eating certain kind of food. And the common allergen in those non-IgE mediated are still the milk, number one, in kids, and soy, rice, and oat, and even meat are seen mainly in adults. For those patients having non-IgE mediated allergy, it's very problematic to have a good diagnosis, because if you order to do specific IgEs, total IgE, skin prick testing, all those will come negative. And the only way to diagnose is to do a complete eviction, then the reintroduction, and you will see if there is any change in the child. So for the IgE mediated, the symptoms can go from urticaria, angioedema, sometimes vomiting in certain kids, sometimes diarrhea, atopic dermatitis, sometimes very rarely rhinitis, and the most worrisome one is the anaphylactic shock. While the non-IgE mediated, they will have mainly GI problems, vomiting, constipation, malabsorption. If you do a biopsy, you can find some villus atrophy and eosinophilic proctocolitis and enterocolitis. So a cow's milk allergy, it's an immune-mediated problem, and it occurs in all ages. It can happen from children in the first few days of life till sometimes rarely in adulthood. Because as you see, the whole cow's milk protein is composed of 80% of casein, 20% of whey. Because the beta-lactoglobulin is not present in human milk, the beta-lactoglobulin that you see, the last one, which is around 50% of kids will have problem with this beta-lactoglobulin once fed a formula. So they can have this problem with the beta-lactoglobulin that also compose a good part of the casein. And the casein are mainly 80% of the cow's milk allergy. So if you want to work on cow's milk allergy, either you have to target the whey or you have to target the casein. If you target the whey protein, you will be able to cure around the 20%. If you target the casein, you will be able to work on 80%, because the cow's milk allergy is a worldwide problem. If you look at the 40% of allergic kids, whatever is their allergy, some 5 to 8% will have food allergies. And from those food allergies, we have around 7.5% that have cow's milk protein allergy that happens early in life. If they have this IgE mediated, their symptoms will happen from few minutes to 2 hours after allergen ingestion. They can have hives, swelling of the lips, face and eyes, abdominal problem, vomiting and diarrhea. And in some cases, it's an medical emergency because they will develop anaphylactic shock, difficulty breathing, tongue swelling, throat swelling, and tinnitus, hoarse voice, and loss of consciousness. While for the delayed type of hypersensitivity, that happens around 24 hours to 48 hours later on, and in very rare cases, 1 week after ingestion, they will have atopic dermatitis, delayed vomiting, delayed diarrhea, and usually you cannot test it. Because in real life, 60% of cow's milk protein allergy will come as a manifestation of GI problem, 50% will come as a dermatological problem, 30% as a respiratory problem, while some kids will be fussy, unable to feed, uncontrollable crying, and having a faltering growth. In front of all those symptoms and signs, suspect cow's milk protein allergy, especially when you have more than one organ affected by the symptoms. There is a scoring system used in Brussels in 2014. It's not very diagnostic, but it's very helpful to see if our child might have a cow's milk protein allergy. It's a scoring, and I hope that you are able to see it on your screen. It tells that we have to check each time how much does this child cry, how much regurgitation does he have, how much he passes stool, does he have any skin problem, does he have any respiratory problem. If he's crying more than 5 hours a day, the scoring will be 6. If he's having regurgitation after each feeding, the scoring will be 6. If he's having 7 watery stools, the scoring will be 6. And each time your final score is more than 12, you have to suspect cow's milk protein allergy. And if the scoring is less than 12 in those 5 questionnaires, you are less likely in front of a cow's milk protein allergy. Because once you have this cow's milk protein allergy, you need to order specific IgEs, and you can sometimes even do a skin prick testing that are very helpful, while doing an atopy patch test is not helpful at all because we don't have any standardization. Total IgE per se by itself is not helpful, and it doesn't give us any idea about if the child is allergic or not. He can be an anaphylactic patient while having a normal IgE level, a total normal IgE level. Doing intradermal tests is very painful in kids, and we don't do that anymore because we have lots of other diagnostic tools. Ordering some specific IgEs antibody for beta-lactoglobulin and alpha-albumin, we still need some standardization for those tests, and we don't have them in Lebanon, so we don't order them. If you are suspecting any protein food enterocolitis or eosinophilic esophagitis, you will order an endoscopy and order a biopsy too. But if you don't have any of those tests, you can do elimination of protein and see if it is working or not. And sometimes doing an oral food challenge procedure with cow's milk is very helpful and diagnostic. For the treatment duration, each time we're having a patient with cow's milk allergy, at least he should get a specific formula for 6 months, and even for a period of 12 months, reaching at least 12 months of age. For the patient who developed a severe IgE-mediated reaction or anaphylactic shock, it's very, very important to wait 12 to 18 months before doing any challenge, and the challenge should be done in a hospital, not at home. We don't allow the patient to try to take cow's milk at home. The extensively hydrolyzed formula, they can help us to treat around 90% of the kids with cow's milk protein allergy. And the AAP defines an extensively hydrolyzed formula, while the peptide should have a molecular weight less than 3,000 Dalton. This number is very important because we'll see later on why. The amino acid formula, it will treat the other 10% that didn't respond to the extensively hydrolyzed formula. The only problem with amino acids is very expensive, and the palatability of this amino acid formula is not very bad. The amino acid formula should be used as a first line in patients with anaphylaxis, in patients with respiratory problem, those who had failure to thrive with hypoalbuminemia, those who had the food protein induced enteropathy, those who have multiple food allergy, those who have short bowel syndrome, those symptoms didn't respond.
ما بدي انزلكم وطلع السمك فرد مرة.
And infants accepting those who have لحظة بس صار في مشكلة صغيرة. سوري.
بس
سوري.
share the screen. اوكي.
يلا صار بس في مشكلة صغيرة. سوري. Okay, هلا we should be using amino acid formula in front of anaphylaxis, respiratory problem, enteropathies, multiple food allergy, short bowel syndrome, while the symptoms didn't resolve under extensively hydrolyzed formula, severe eczema, and eosinophilic esophagitis. What we should not do, we should not use a partially hydrolyzed formula to treat cow's milk protein allergy. Even this partially hydrolyzed formula is not intended to prevent allergy later on. And the only recommended by the SPGAN is the extensively hydrolyzed formula. Using soy protein-based formula, as you all know, is not intended to treat any allergy, and should not use it because they lack lots of nutrient. Even using sheep and goat milk are not indicated anymore. Rice protein-based formula are not also indicated to treat allergy. Each time you are facing allergy and you have to treat it, you should use extensively hydrolyzed formula and amino acid formula only. Sometimes when the patient is having cow's milk protein allergy, the symptoms would be like gastroesophageal reflux. Up to 40% of gastroesophageal reflux in children and young children is only caused by cow's milk protein allergy. And if you try to do skin prick testing for a patient with reflux, you might have 55% of them that are having allergies and GERD. That's why we have a formula, an vanity formula made of extensively hydrolyzed casein with 97% of their molecular weight less than 2000 Dalton. And they have a double mode action because it's a second formula with treated cornstarch that gives this formula a high viscosity that will treat the symptoms of gastroesophageal reflux. This Novalac Allernova is 100% casein protein hydrolyzed. The maximum molecular weight of those protein and shortened protein is less than 2000 kilodalton. It has the lowest molecular weight compared to other formula, and it has an acceptable taste compared to other extensively hydrolyzed formula. It's a lactose-free to prevent secondary lactose intolerance. Yalla, I will finish in a few minutes. With possible taste of cow's milk protein allergy, with a good carbohydrate profile, maltodextrin and starch, and also added MCT. What we should keep in mind that this formula will help us to treat patients with cow's milk protein allergy, and we are treating around 90% of those patients. The other 10% will need amino acid formula. It is tolerated by 90% of kids, clinically proven to improve and to show a good improvement after adding this formula in patients with allergies. It will help us relieve symptoms from cow's milk allergy and gastroesophageal reflux management. It's a complete nutritional formula with a good taste, and it is accepted by children and suitable from birth till the age of 3 years. لأنه عادة after the age of 3 years, we will be facing rarely allergic kids. Okay. And here is my presentation. I'm done with it. Thank you.
Thank you. Good. So thank you for all. In this end of this webinar, I would like to thank all speakers, amazing speakers, really, and moderators and participants. Of course, thank for Dr. Hadi for the effort to organize this webinar, and Dr. Majdalani for supporting of all of us. And of course, thank you for Mr. Khazal, the pro team. And I want to take this opportunity to congratulate all the mothers in the big days, Mother Days, and of course the mom mothers, doctors, and wish to all of them peace and happiness. Hope we had enjoyed all this webinar, and thank you all. And I hope next year's it will be in LPS. Hope the coronavirus will be the end in this year. And thank you for all.
Thank you. Bye-bye.
Bye.
Thank you. يعطيكم العافية. يلا باي باي. See you again.
يعطيكم ألف عافية.
يلا يعطيكم العافية جميعا.
ظبطوا هالسبمشن فورم؟
مش الحال.
لأنه ما عم تزبط.
لا نظبطها. يعطيكم ألف عافية. Have a nice.
يعطيكم العافية. باي باي.
عاد على كل الأمهات. يلا باي.